nyata, jiwa wirausaha, akhlak mulia, profesional, responsif, inovatif, modern dan bangun entrepreneur. Kita mencintai, kita unai hati, kan empati, tanggung jawab, disiplinkan diri, The Prime Medicine Faculty. Kita unai, kita mencintai, kita unai hati, kan empati, tanggung jawab, disiplinkan diri, The Prime Medicine Faculty, The Prime Medicine Faculty.
Good evening, ladies and gentlemen. Welcome to the 65th Airlangga webinar conference series. Joint meeting Airlangga Global Ophthalmology, Phacoemulsification from routine to challenging cases. My name is Wina, along with my pediatrics and my colleague Rahul, Kevin, and Arya. We are the organizing committee webinar. This webinar is organized by the Faculty of Medicine, Universitas Airlangga, Surabaya. Before we proceed to the main event, we will announce some of the rules regarding the certification and Q&A session of this webinar. Rules for ED accredited certification. Your attendance will be recorded by the Zoom application. By the end of this webinar, participants are required to fill a questionnaire, which the committee will send the link of in the chat box. The certificate will be sent to your registered. Rules for Q&A. Use the Q&A box on the middle of your Zoom panel to. Questions will be sorted and discussed after all lectures have been presented. Thank you for your participation, and we sincerely hope you can enjoy this webinar. We will start this webinar with an opening remarks from our beloved host, Dr. Muhammad Nurdin Suhri, specialist on ophthalmologist. Dr. Muhammad Nurdin Suhri, the time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good evening, dear senior and colleagues. Thank you everyone for joining in our webinar tonight. I'm delighted to welcome you to the first meeting Airlangga Global Ophthalmology. This webinar is part of Airlangga Webinar Conference Series initiative from Universitas Airlangga. Zuhri, ophthalmologist from Universitas Airlangga, and I will be your host for the next 3 hours or so. Before we proceed, we will sing the Indonesian national anthem, Indonesia Raya, and hymn Universitas Airlangga. Thank you. We are still very much in the middle of many challenges we face. COVID-19 has its silver lining. It brought the world together in a way that never could before, just like this evening. Now, I would like to welcome Prof. Budi Santoso, Dean of Medical School, Universitas Airlangga, Prof. Nasruddin, CEO of Universitas Airlangga Academic Hospital, us tonight, Prof. I would also like to offer our warmest welcome to the distinguished speaker, giants in ophthalmology that I'm sure and Dr. Aik Ahmed from University of Toronto, Canada. Without further ado, I would like to invite the beloved head of Department of Ophthalmology Department, Universitas Airlangga, to give opening speech. Dr. Evelyn, please, time is yours.
Thank you, Dr. Nudin. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Good morning and warmest welcome to our highly esteemed speakers here all the way from Toronto, Canada, Dr. Steve Asinov and Dr. Aik Ahmed. Thank you for taking your time to be here today with us all. It is an honor to have you. Welcome to Dr. Ramdhani on behalf of Professor Budi Santoso, Dean of Medical School, Universitas Airlangga, and Professor Nasruddin, the CEO of Universitas Airlangga Academic Hospital. And thank you for all participants for tuning in the first event joint meeting Airlangga Global Ophthalmology or first JAGO. I also would like to thank organizing committee, Universitas Airlangga Academic Hospital, Universitas Airlangga and University of Toronto for making this webinar possible. We look forward to continuing this constructive collaboration and friendship. Thank you so much and wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Salam warahmatullahi wabarakatuh. Next, we will hear the opening speech from the Dean of Medical School, Universitas Airlangga, who will be represented by Dr. Ahmad Husnu Ramdhani. Please join me in welcoming speakers and participants of tonight's webinar.
Okay, thank you, Dr. Nurdin. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat malam dan salam sejahtera untuk kita semua. Good morning in Toronto and good evening in Surabaya. Segala puji bagi Allah SWT atas berkat rahmatnya kita semua masih diberi kesehatan dan kesempatan untuk dapat berkumpul secara virtual. And welcome to joint meeting Airlangga Global Ophthalmology or JAGO with topic Phacoemulsification from routine to challenging cases. Distinguished speakers and participants, First of all, on behalf of our Dean, I would like to express my sincere gratitude to Head of Department of Ophthalmology, Dr. Evelyn Komarate, Spesialis Mata Konsultan, our honorable speakers today, Dr. Diki Hermawan, Spesialis Mata Konsultan, as the head of the Cataract Division, Refractive Surgery, Department of Ophthalmology, Universitas Airlangga, who will talk the topic about phacoemulsification in difficult cases. Our special guest and speaker today, Stephen Arsinov, MD, FRCRC, as the Associate Professor of Department of Ophthalmology and Vision Sciences of University of Toronto, who will present the topic about phaco-dynamic in simple and complex cases. And also our special guest and speaker today, Aik Ahmed, MD, FRCRC, as the Assistant Professor of Department of Ophthalmology and Vision Sciences of University of Toronto, will deliver the topic about interesting cases of phacoemulsification video session. And also the Director of Universitas Airlangga Academic Hospital, Profesor Dr. Nasruddin, Dokter Spesialis Penyakit Dalam, Konsultan Penyakit Tropik Infeksi Vinasim. Our distinguished host, Dr. Muhammad Nurdin Zuhri, Spesialis Mata, as the member of the Division of Neuro-Ophthalmology, Department of Ophthalmology, Universitas Airlangga, and staff of the Department of Ophthalmology, Universitas Airlangga Hospital. Our honorable moderator, Dr. Indri Wahyuni, Spesialis Mata Konsultan, Chair of Committee and the member of the Cataract Division, Refractive Surgery, Department of Ophthalmology, Universitas Airlangga, and the team of AWCS, Dr. Asra and Dr. Boy, and also seniors, staffs, and residents of the Department of Ophthalmology, as well as our colleagues from other departments in the Dr. Sutomo General Hospital, Faculty of Medicine Universitas Airlangga. Sejawat sekalian, sebagaimana yang kita ketahui bahwa katarak merupakan penyakit mata yang ditandai dengan kekeruhan lensa mata sehingga mengganggu proses masuknya cahaya ke mata. Berdasarkan data WHO pada tahun 2010, sebanyak 285 juta orang di seluruh dunia mengalami gangguan penglihatan, di mana 39 juta mengalami kebutaan dan 246 juta mengalami low vision. Katarak sendiri menyumbang 33% penyebab gangguan penglihatan di seluruh dunia, di mana katarak merupakan penyebab kebutaan terbanyak, yakni sebesar 51% dari seluruh kasus. Di Indonesia sendiri, katarak merupakan penyebab terbanyak kebutaan, yakni sebesar 77,7% dari semua kasus. Kebutaan akibat katarak merupakan kebutaan yang dapat disembuhkan, yakni melalui operasi. Teknik operasi yang digunakan bisa berbeda-beda tergantung jenis katarak dan sarana prasarana yang tersedia di fasilitas kesehatan tersebut. Phacoemulsification adalah gold standar untuk operasi katarak di negara maju, sedangkan operasi katarak manual, sayatan kecil manual, MSICS seringkali digunakan di negara berkembang. Dan sebagaimana yang kita ketahui bahwa di setiap prosedur operasi pasti terdapat penyulit-penyulit khusus, tidak terkecuali operasi katarak ini. Akan tetapi perkembangan perangkat tambahan serta pelatihan dan pengalaman bedah yang lebih baik diharapkan mampu meningkatkan prognosis operasi katarak sehingga mendapatkan hasil visus yang optimal. Dengan demikian, diharapkan melalui webinar ini mampu memberikan pemahaman kepada para peserta mengenai prinsip-prinsip phakodinamik dan teknik-teknik phacoemulsifikasi, beserta gambaran teknik khusus dalam menghadapi kasus-kasus sulit sehingga mampu memberikan hasil operasi yang optimal. Para hadirin, oleh karena itu, saya selaku Wakil Dekan 1 mewakili Bapak Dekan Fakultas Kedokteran Universitas Airlangga sangat mengapresiasi adanya webinar ini. Besar harapan saya, acara ini dapat menjadi salah satu forum strategis bagi para sejawat sekalian untuk mengupdate ilmu, menambah wawasan, memperluas jejaring, yang tentu sangat bermanfaat untuk peningkatan kualitas pelayanan, khususnya dalam bidang kesehatan mata di Indonesia. Semoga webinar ini dapat berjalan lancar dan dengan mengucap Bismillahirrahmanirrahim, acara Joint Meeting Airlangga Global Ophthalmology JAGO with topic Phacoemulsification from routine to challenging cases, secara resmi saya nyatakan dibuka. Thank you very much for your attention and please enjoy the webinar. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Now I would like to invite Prof. Nasronuddin, CEO of University. Time is yours, Prof.
Thank you very much to Master of Ceremony. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Good evening, ladies and gentlemen, and good morning in Toronto. Honorable Mr. Stephen Aaron Arsinov, MD, VRCRC from Ophthalmology and Vision Sciences, University of Toronto, and also Honorable Mr. Ike K. Ahmed, MD, VRCSC from Ophthalmology and Vision Sciences, University of Toronto, Honorable Ahmad Husnur Romdoni, MD, PhD, Vice Dean Medical Faculty, Airlangga University, and also Honorable Mrs. Evelyn Komarate, MD, PhD, Chairman of Ophthalmology Department, and all staff, Honorable Diki, MD, Ophthalmologist, and also Honorable Muhammad Firmansyah, MD, Ophthalmologist, Consultant, Head of Perdami East Java, Indonesia, and all members, and Dr. Nurdin, MD, Ophthalmologist, and all team of organizing committee in this meeting, all speakers, all moderators, and all audience. First of all, let's meet thanks to God following this meeting. Today, we held Airlangga webinar conference series, joint meeting, Airlangga Global Ophthalmology and Vision Science, Toronto University. On behalf of Airlangga University Teaching Hospital, we are very happy and full support in this joint meeting. We hope that this meeting can increase our knowledge, especially in ophthalmology science. And also, we hope that this meeting not only stop in this webinar, but also we can join furthermore in Tri Dharma Perguruan Tinggi, including here, especially in education, through interprofessional education, and in health services, through interprofessional collaboration in health services, and in research through interprofessional collaboration and research between Airlangga University Hospital and Toronto University. Finally, thank you so much for you all participants, and see you again in the next time. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Salam.
Assalamualaikum warahmatullahi wabarakatuh. Thank you, Prof. As we all know, cataract surgery is bread and butter in ophthalmology. There is a steep learning curve for resident and young ophthalmologists. Also, in refractive surgery, good is never enough. We should continuously strive for better. Speaker, I sincerely hope that you enjoy tonight's program. Dr. Indri Wahyuni, our own cataract surgeon here, to join us and moderating the following session. Please, Dr. Indri.
Professor Budi Nasruddin, I feel, sorry. Thank you, Dr. Nurdin. Good evening to Dr. Evelyn. Good evening to Dr. Evelyn Komarati, Dr. Romdoni on behalf of Professor Budi Santoso, Professor Nasruddin, Thank you for taking your time to be in this event despite on your very busy schedule. I feel very honored to welcome Prof. Steve Arsinov, Dr. Aik Ahmed, and Dr. Diki Hermawan. Thank you all for your willingness to be a speaker at this event. We really appreciate. I also want to welcome all participants in this webinar. Warmest greeting from Surabaya. We are deeply moved by the enthusiasm from all of you. Currently, we have more than 1,000 participants watching from Zoom and YouTube. I believe we will have knowledge in this first JAGO, joint meeting of Airlangga Global Ophthalmology. My name is Indri Wahyuni. I'm delighted to be your moderator of tonight. This webinar consists of 2 sessions, presentation and discussion, and we have 3 speakers. The first speaker in this webinar is Dr. Diki Hermawan. Dr. Diki Hermawan will be presented. Times is yours. Dr. Diki Hermawan is the head of Cataract and Refractive Surgery Division of Ophthalmology Department Universitas Airlangga. He is a lecturer for ophthalmology resident in Universitas Airlangga and has completed fellowship in Rajan Eye Hospital, Chennai, India in 2010, in-house training for LASIK and SMILE at JAC. He is a very experienced who has performed a great number of phacoemulsification procedures in complex and challenging cases.
Thank you, Dr. Indri, for the kind introduction, and thank you for the committee for having me here to present a topic, phaco in difficult cases. Good morning, Prof. Arsinov and Prof. Aik from University of Toronto, Canada, and good evening, my senior and colleagues in Indonesia. Today, I will share with you all about phacoemulsification in eyes with pre-existing glaucoma and in subluxated lens. Phaco in glaucomatous eye. Biometry for this patient showed that the 3 mm anterior chamber depth, 5.17 mm lens thickness, 22.71 mm axial length. He was on timolol 5% and benzolamide eye drop. We don't have a video overlay facility yet, so unfortunately I cannot show you my phaco machine parameters on the screen. But I can tell you the parameter of the phaco machine that I used at that time was button height 85 cm, aspiration flow rate 32, and vacuum 450. During the surgery, I noticed the anterior chamber getting shallow, and after the segment removal and inserting the IA handpiece into the anterior chamber, I left with no space. The IA tips to the posterior capsule, the capsular bag collapse, the anterior and posterior capsule touching each other. At that point, I decided to stop the operation and gave astaxanthin 500 milligrams tablet. And I resumed the surgery 45 minutes later to allow the anterior chamber deepened. Continuing the surgery is a real risk again times, so I had to do it in the most efficient manner. Otherwise, the anterior chamber will getting shallow again. In the end, I was able to complete this operation. Yet due to the iris prolapse yesterday, I decided to put suture at the main incision. During phacoemulsification or irrigation aspiration, the anterior chamber might become shallow and the lens or posterior capsule might bulge anteriorly because of Inadequate infusion leakage through an oversized incision, external pressure on the globe, positive vitreous pressure, fluid misdirection syndrome, suprachoroidal effusion, or suprachoroidal hemorrhage. In this situation, the eye typically becomes very firm and the patient becomes agitated and complain of having pain. In my patient, the situation that may occur was positive vitreous pressure or fluid misdirection syndrome. Posterior vitreous pressure or forward displacement of the lens iris diaphragm occurs more commonly in obese or thick-necked patients, patients with pulmonary disease such as chronic obstructive pulmonary disease, and patients experiencing a level of anxiety or discomfort that may lead them to squeeze their eyelid or perform a falsafa maneuver. Intravenous mannitol can be used to reduce the vitreous volume and deepen the anterior chamber in selected cases. In the posterior fluid misdirection syndrome, what happening is the irrigation fluid which infused into the anterior chamber might be misdirected into the vitreous cavity through intact zonular fibers or through a zonular or capsular tear, causing an increase in the vitreous volume with subsequent forward displacement of the lens and shallowing of the anterior chamber. And another way, the fluid may accumulate in the retrolental space or dissect posteriorly along the vitreoretinal interface. If gentle posterior pressure on the lens or reinflation of the capsular bag with OVD does not alleviate the situation, intravenous mannitol infusion and waiting at least 20 minutes may allow the anterior chamber to deepen. And then phaco in subluxated lens. This situation can occur in two cases. First, in the condition of the lens subluxation prior surgery due to different causes. Second, in the case of hard cataract, which excessive manipulation is carried out. In this video, we have a subluxated lens of about 180 degrees. We place an iris retractor for the capsule hook and capsular tension ring. Patient had a shear length of 26.68 mm. After that, we continue the phacoemulsification by lowering the height of the bottle, increasing the US power, yet other than that we don't change the parameter. A control and gentle movement is the key here to avoid unnecessary extra maneuver which can cause the zonule to be future damaged. Common causes of zonular incompetence include pseudoaspiration syndrome, ocular trauma, prior vitrectomy or trabeculectomy, and high myopia. Zonular incompetence becomes apparent intraoperatively with iridogenesis, phacogenesis, disintegration of the capsular bag, and sometimes vitreous prolapse into the anterior chamber. Zonular status may be determined by direct visualization of the lens equator through a widely dilated pupil or by use of a gonio lens to visualize zonular fibers behind the dilated pupil. In the case of dense Brunesen cataract, surgical manipulation increases the risk of iris trauma, zonular tearing, capsular rupture, vitreous loss, and the dropping of lens fragment into the posterior segment. Increasing ultrasound energy required for phacoemulsification of dense lenses might increase the risk of endothelial trauma and bone burn. Creation of a larger capsular recess is helpful, as it allows the surgeon to perform the maneuver that are necessary to minimize this complication. Through introdissection and hydrodynation of the nucleus, facilitated smooth rotation during phacoemulsification. When an initial groove is made in the hard nucleus, it is important that the surgeon make a deep and even pass so that the nucleus crack without leaving interdigitation. Such interdigitation interfere with removal and can lead to posterior capsule rupture. In the operative examination, if zonular disruption encompasses over 120 degrees, the surgeon may consider removal of the cataract using extracapsular cataract extraction (ECCE) or intracapsular cataract extraction (ICCE). Otherwise, phacoemulsification can proceed safely with application of the same measures recommended in the hard cataract. Excessive mechanical maneuver in the nucleus, cortical aspiration, or inadvertent aspiration of the anterior capsule is contribute to future zonular compromise. Reducing the flow rate diminishes turbulence and fluctuation in the anterior chamber depth, lowering the risk of vitreous prolapse through the area of zonular absence. And again, a larger capsulolysis allows easier separation of lens component with the capsular bag. Thorough hydrodissation and hydrogenation of the nucleus facilitated smooth rotation during phacoemulsification. Viscodissation of cortical remnant on IOL insertion prior to complete cortical removal are maneuver that help maintain capsular integrity. Tangential rather than radial removal of cortex from the back minimize cellular stress. If capsular is sufficient for safe phacoemulsification, capsular hooks or a CTR or CTR segment can be used. Capsular hooks support the anterior capsule in the area of weak cellular fiber. They are placed to photosynthesis incision and adjustment of tension on each hook recenter the capsule for phacoemulsification. CTR provides support by exerting centrifugal force against the capsule equator to area of absent or weakened cellular fibers. Because radial tension may further extend the capsular defect, placement of either capsular hooks or a CTR should be avoided if the anterior capsule is torn radially or if the capsular access is interrupted. With a CTR in position, the surgeon can proceed to nuclear and cortical removal more safely and place the chosen IOL in the capsular bag. Insufficient cellular support can also be managed with a modified CTR or CTR segment sutured to the subcleral wall. If the surgeon uses excessive mechanical force on a nucleus that does not freely rotate it, cellular dialysis may result from transmittal of that force to the capsular bag. Mechanical segmentation technique of nucleus disassembly, such as vertical and horizontal chopping, require less ultrasound energy and may induce less cellular stress than the divide and conquer method. Familiarity with multiple techniques and the ability to switch from one technique to another as the situation requires enable the surgeon to minimize complication. If phacoemulsification ceases to be an appropriate technique for lens removal, conversion to an extracapsular technique should be considered. The surgeon must decide whether to proceed through the corneal incision by enlarging into the permit passage of the cataract and lens implant, or alternatively, the corneal wound can be closed and the new larger corneoscleral incision created in the superior portion of the eye. The last but not the least, there are times when it is important to convert from phaco approach to ACCE or ICCE in order to give the patient a better outcome. Here is the main reference that I use for this presentation. To close my presentation, I would like to remind us all that life is 10% what happened to you and 90% how you react to it. So hopefully after we learn today, we will be better on reacting to whatever cataract throw at us. Thank you and please stay safe and healthy. Thank you, Dr. Indri.
Thank you, Dr. Diki, for the presentation. It's very interesting presentation. I would like to remind all participants to drop your question in the Q&A chat box. Our speakers will answer your question in the second session. Untuk menuliskan pertanyaannya di Q&A chat box yang nanti akan dijawab oleh para pembicara kita setelah sesi kedua. Now we are going to continue with our second speaker, Prof. Steve Arsinov, with the topic phaco-dynamic in simple and complex cases. I believe this is a very interesting topic for both seasoned ophthalmologists and ophthalmologist resident. Good evening, Prof. Arsinov.
Good evening.
Okay.
Thank you very much.
I hope you. It's still very early in Toronto. Thank you for taking your time to share your knowledge and wisdom with us.
Thank you.
Let me just share my screen.
Okay.
But I think someone else is sharing their screen, so I can't share mine.
Yes. Prof.
Okay.
of Ophthalmology and Vision Science, University of Toronto. Prof. Arsinov has authored more than 300 peer-reviewed publications, 38 medical textbook chapters, presented more than 1,000 academic lectures worldwide with areas of research interest in ophthalmic, surgical device, surgical techniques, phacoemulsification machine design, and medical outreach program.
Okay, thank you very much. First, I would like to thank you for inviting me and Dr. Ahmed and the University of Toronto Department of Ophthalmology and Vision Sciences to take part in your webinar. From what we've heard so far, it's going to be a fantastic webinar, and I sincerely hope that my good friend Ike and I can contribute beneficially to the presentations. So these are my disclosures on the bottom of the slide here. I hope you can see it. And I've been interested in phaco machines and devices that we use in ophthalmology for a long time. I did my first phaco when I was a resident, and I was one of the few who was not afraid of machines. And so in 1978, when I was just starting to take interest in ophthalmology, I was asked to help one of my mentors who got the first phaco machine in Toronto, and no one was brave enough to use it with him. But I had some background in engineering, and I was more than happy to play with toys. So I've been interested ever since. The first machine that I was actually involved with was the Alcon Infinity, and here is a 2010 version, but I was involved since about 2000 in meeting in California with the engineers once a year and helping to design them. And I'm going to talk about this and some other machines and some other things about phaco machines that I think will help you, and other devices that we use that I think can just make your surgery easier, and really some general principles and not specific things. And Ike will later talk about cases that he'll show you, some interesting cases. So the question is, when you work to design a phaco machine, is what do you want your phaco machine to do? You know, you often go into places and you see that people have like dozens of buttons on their machine to push and play with, and they change their settings frequently. But I don't want my phaco machine to do that, and I never did want to have a machine of that design. I want my machine to run automatically like the finest automatic cars. So I can't imagine getting into a very expensive car and having to keep pushing buttons on your dashboard every time you go up a hill or down a hill or turn a corner. All I want to do is gently push the gas pedal, and I want the machine itself to adapt, knowing that I'm pushing the pedal further because I'm dealing with a more dense cataract. The same as the car knows you want to go faster, and it adjusts the carburetor and everything else, and you don't have to do anything. And so as that happens, I want the phaco machine to quickly eat up and give me a sensation that I'm getting somewhere without placing stress on the capsule or without aspirating the vitreous. So what I really want to do is I want to do all my cases the same way, but differently. So all I want to have to do is depress the foot pedal and do a few subtle things, but have the machine adapt to everything else and help me do it. So in that idea, I'm going to talk to you about phaco machines and some things about it. Okay, so let's talk about some problems and how we can avoid them easily as we get into this. The first thing you hear about is wound burns. People always complain about they might get wound burns or are terribly afraid of it. It is the simplest thing to avoid. Just use pulse. If you pulse your phaco machine, that means that half the time at least it's going to be off, and so you won't be generating a lot of heat. And what I have designed for machines that I use is a procedure called continuously variable pulse, and I will show you that as we go along, so that you don't tend to get any heat from at the base of the needle and you don't burn wounds at all. When you go into an eye, if you have the anterior chamber full of OVD, aspirate a little bit of it, or else use an ultimate soft shell technique where you place a small layer of balanced salt below the OVD. So you never have a space that is entirely full of OVD with your phaco machine on significant power, and so you don't generate heat and you don't burn things. All OVDs can produce burns if used inappropriately, but dispersives are worst because they come out in little pieces and not all together. The other problem we often hear about is dense lenses. People break capsules more often dealing with dense lenses. and they dislocate the lens and they, break the zonules. And I think the trick to this is to take your time, to not expect a dense cataract to go as quick as an easier one would, and to take the nucleus and impale it on the phacotip. So really, what you're doing is you're pushing against the phacotip when you try to chop the nucleus, and you're not pushing against the zonules or against the lens, because pushing against the lens pushes against the posterior capsule, and pushing the lens away from you pushes against the zonules. The thing I found the most helpful in the last number of years for dense lenses is to use femto. And I know in many places there's a financial disincentive and a problem to do that, but I can tell you that femtos make dense cataracts much, much, much easier. And a very soft lens, people are often afraid of doing very soft lenses because they find that they can grab the capsule or go through the nucleus. And I think all you want to do is gently cut the lens in half with your chopper and then aspirate each piece, really using your phaco as an IA device and not applying any force. To avoid damage to endothelial cells, learn to use OVDs well, use things like continuously variable pulse. You don't need to have high flow rates. High flow rates just cause more endothelial damage and don't really help you usually. To avoid posterior capsular tears, just support the nucleus on the phacotip, don't push against the posterior capsule, and don't sculpt. Since the initial phaco chopping techniques in the 1990s, I basically have not sculpted anybody ever. I think it just pushes against the zonules and increases your risk of having complications. It's much easier to hold the nucleus and to chop it. If you find your phaco too slow or inefficient, my advice is don't rush. If you learn to do your phacos better, you'll gradually go faster and things will appear more efficient. Use continuously variable pulse, don't use multiple settings. Just take your time and learn to do things better, and you'll find that as time goes on, it will take you less time and will go more smoothly. It's just practice like anything else. One of the things I always talk to students, fellows, residents about is how they hold their phacotip. It really bothers me when I go and I see someone holding a phacotip like a pen, because it makes it hard to maneuver it in the eye. And if you have to move it a little bit, it's very difficult. So I give everyone the analogy of holding a phacotip like holding chopsticks. And there's two chopsticks, the top one and the bottom one. And if you look at these pictures over here, you'll see the top one is the one you can move. And the bottom one, which is being held like a pen, you can't move. So you don't want to hold things like the bottom chopstick. You want to hold it in your fingers, so with your thumb between the next two fingers, so that you can maneuver the phacotip easily. And I'll just show you the difference over here in these two videos. So here it's supposed to show the video. So here you see me holding it like a pen, and it's actually, you can move it, but not very much. And in the other video, watch how much I can move it when I'm holding it like a chopstick between my thumb and the next two fingers. You can turn it all over the place. It's very, very easy. So if you learn to hold your phaco like the top chopstick, and you maneuver a bit when you first get into the eye to make yourself comfortable, you'll find that your phacos are much, much easier without really having done anything to make life more difficult. So it's an easy thing to do. The next thing you want to look at is, I find very often the nurse will hand me the phaco handpiece and the sleeve isn't on quite right. Like it's close, but not quite perfect. And the first thing you want to do is to make sure that the sleeve is sealing here against the phacotip. If it doesn't seal, the fluid is right down, the irrigation fluid, in front of the phacotip and washes the nucleus off the tip as you're trying to phaco it. So it makes your cataract surgery much more difficult because you're trying to aspirate the nucleus and the fluid is washing it away. If you seal it, and all of the phaco sleeves will seal if they're put on properly and the right one for the right tip, then it's going to stop the flow where the seal is, and it will come out the side ports and not down the end. And then make sure that you recess the sleeve so that you don't get flow axially along the tip, and you can aspirate the nucleus with less force to get it to work for you. It just makes your life a lot easier, and spending 2 seconds before you start your case to look how the nurse put the sleeve on will help you quite a bit. So the big thing is to understand how phaco machines work. And this I find is the most difficult thing to teach people because nobody likes math these days. But it's really, really, really math that you learned in about grade 6. And you can attract
or you can understand really everything about how a Phaco machine works if you actually learned about electricity in grade 6. And in electricity, electricity is the same because it's a fluid flowing along wires as fluid is flowing in your Phaco machine. So you have this simple equation, which is called Ohm's law, and is E is equal to IR, which means the force is the flow times resistance. So we also know that pressure is force over area, and I'll discuss pressure later, but let's discuss this first. Okay, so then you have to say, well, if these are the issues that we're dealing with, which one of these factors is which in cataract surgery, and how does the machine deal with it? Well, we all think that the force is the vacuum that we set. It's true, but in many machines you don't set the vacuum. But it's also the bottle height, because it's not just the pulling force of the vacuum, but the higher you place the bottle, then the more force you're going to have. So you have a pushing force from the bottle height and a vacuuming force from the Phaco machine. Both of those count in the force. The Centurion is a bit different from older machines in that it actually sets pressure. So it sets this, and the pressure in millimeters of mercury is about 3/4 of what the bottle height is in centimeters of water in other machines. And the advantage of this is it means the machine is trying to compensate for leakage in the eye or any other abnormal situation, a kink tube or something, to maintain the pressure to be same and constant in the eye. So that's just force. And then we have flow. Well, the flow is the aspiration flow rate we set on our machine. But the other aspect of flow that's critically important to consider is wound leakage, because wound leakage is something that is due to making too big an incision. And if you do that, it means you no longer have any control over your cataract surgery. If you have excessive wound leakage, the Centurion cannot set the pressure in any stability, and none of these things are going to work, and the equation fundamentally doesn't work because you have one unreliable factor in the equation. And then the resistance is the aspirate viscosity, the density of the lens, divided by the port area, but it's also the tubing resistance. You'll notice that every time you get a Phaco machine, the company will tell you to use just their tubing, and it has very specific length, very specific rigidity, and every company designs theirs differently for the resistance it generates and how it wants their Phaco machine work. So when you look at this equation, and we see these different factors, I put a check mark here because we can really control these. We can control the vacuum and the bottle height. And I put a check mark here because we can control the tubing resistance. We have no control whatsoever over the density of the nucleus, but we know as we look into the eye how dense it is. And we can control the flow, but we can't control wound leakage. So the thing you learn from this is don't make leaky incisions. If you make leaky incisions, you've just made your Phaco machine try to work in an environment that it is not designed to work in. So it does not work very well. So what does that mean for Phaco machines? Well, so if you look at this equation, and resistance we know is out of our control because that's the cataract density. So the machine, what it does is it sets one independent variable, and that's the machine thing that you set, and one is dependent. And you can only set one of either force or flow, and different machines set them differently. So peristaltic pumps will set the flow. So when you turn and dial the flow in, that's what you're adjusting. Everything else is constant. And what that means is that the force that you generate when you occlude the port is a function of the resistance. All right? Okay, what does that mean in reality? Because most of us don't like looking at math equations. It means that the vacuum increases and builds up when the nuclear density increases. But what it also means is that when we finish eating the nucleus and resistance goes to zero, the force is proportional, and so the force will go to zero. So these machines are designed by the nature of how the pumps work, not to generate surge. And so you'll see that when you use a peristaltic pump, the reason most Phaco surgeons like peristaltic pumps is they don't cause surge, or they cause very little surge. You also have some elasticity of tubing, which can cause a little bit of surge, but not very much. But how about vacuum pumps or Venturi-based pumps? Some people like Venturi pumps. Well, in those machines, you set the vacuum. That becomes your independent variable. And flow then varies as 1 over resistance. Simple math. What happens when you get an occlusion break with a Venturi pump? Well, if R goes to 0 in this equation, what happens is that flow goes to infinity. So you get huge surge. The initial problems with the first venturi pumps, why they weren't popular in the 80s and 90s, was because you had tremendous surge in these machines. And how did they get around it? Well, there are always engineering ways to get around everything. And what the companies do who manufacture the machines is they put sensors all along the line, and the sensor detects what's happening, and then it stops it. So when you start to get surge, the sensor will turn off the vacuum. So then the vacuum goes to zero and the whole thing goes to zero. So that's how they compensate for it. So, but if you look at this equation, which I know nobody likes, and you take these two slides and you stare at them for a half an hour or an hour until it's really part of your brain, you will understand how your phaco machine works. Until you understand what you're doing and how this works, you will have a difficult time doing your phaco machines. So I mentioned pressure with respect to the Centurion machine. And a couple of years ago, Rami Malek made Bohemian Rhapsody famous, and I showed you a little bit of music just to be amusing. But what I want to talk about is pressure induction, because most of us don't ever talk about pressure in phaco machines, but you have to understand that the first reason that we had OVDs in 1980 when Helon came on the market was to induce and sustain pressure in the eye so we could insert a lens into a patient who had intracapsular cataract surgery. And so pressure really is a very, very important part of how we do our surgery and how we maintain our surgery. So you saw in the case you just saw from Dr. Hermerwan, where the chamber was shallowing, that meant that the pressure was not higher in front of the capsule than it was behind it. So he had to do something either to lower the pressure behind it, which he gave Diamox, or to raise the pressure in front of it, which could have been using an OVD or whatever. And so pressure is critically important to everything that we do. And for what parts of things is pressure critical? Well, when you do a capsulorhexis, it's very important because we induce pressure in front of the anterior capsule to prevent getting Argentinian flag sign. And when you want to rescue an errant capsulorhexis, you do the little tear-out rescue, and I will show you later how that also is done by inducing pressure in front of the capsule. So the first time that you see a capsule beginning to go errant and going out, the simplest and most effective thing to do is inject a very viscous cohesive OVD in front of that capsule to increase the pressure in front of the capsule higher than the pressure behind it, and then the capsule will tear in. Our phaco machines all induce pressure in the eye. The Centurion tends to put your pressure between 40 and 75, and in other machines, we adjust the pressure by raising and lowering the bottle, but we're not raising and lowering the bottle to increase the flow rate, we're raising and lowering the bottle to increase the pressure in the front of the eye. And we raise it to about this level also with other machines. When we do IA, as you saw in Dr. Hermerwan's case, what he wanted to do was raise the pressure in front of the capsule to push back the posterior capsule, open the bag, and allow him to do IA. So the anterior chamber pressure really pushes the capsule back and allows us to not aspirate the capsule when we aspirate the cortex. So pressure is critical here too. To implant a lens, we have to somehow expand the bag so we don't snag the posterior capsule with the ingoing lens and then tear it. I'm going to talk to you later about assuring a free cap in flax and how we can use pressure for that. And if you think about it, for every problem type case that we deal with, we do something to change pressure to make it work better for us. So then let's think back and see how each of us do cataract surgery. We're in different parts of the world. We have different devices that we like to use or we have available to us. And we all develop our own technique of cataract surgery. And if you think about it, your technique is really very much dependent on what kind of a pressure environment you work in. I happened to be involved consulting for Pharmacia when they first came out with Helon and Helon GV and Helon 5. And so I became accustomed and liked to do surgery in a high pressure environment. So the eye is very stable. Now, high pressure with OVDs doesn't mean 70, it means about 20, 25 in the eye. So everything is held very still doing surgery. And people who like to use viscous cohesive OVDs tend to prefer to work in a relatively high pressure environment. And then there are those who work in a lower pressure environment. If you like to use Helon or Viscoat or similar devices, you're actually working in an intraocular pressure level of about 5 or 10. It's actually quite low. And all medium viscosity cohesives and dispersives tend to induce that pressure because if you try to raise the pressure higher than that in the eye with the OVD, it starts to leak out. So you don't get very high pressure. And then you have a large part of the world where people use very low pressure surgery because they use hydroxypropylmethylcellulose for their surgery, and HPMC is quite liquid, and as a consequence, you really can't raise the pressure above like 2 or 3 in the eye. The eye is basically soft the entire time you're doing surgery. And so those who use these techniques have adapted to different methods of doing surgery where they can get by with low pressure in the eye. But it's important to remember that your surgical techniques are based a lot on what pressure you're used to working. So when do you want to use high pressure? Well, the main one is to deal with Argentinian flag sign. So when you get Argentinian flag sign, the reason we get a tear out is simply because most people don't understand fundamental rheology. And all you have to do is increase the pressure in front of that capsule higher than what's behind it to make the capsule tear in. So here's a model, a schematic of what happens to an eye. We always have pressure because the muscles aren't paralyzed and they're pulling posteriorly. Newton told us that if the muscles pull back posteriorly and the sclera is sitting here on the opposite side of the sclera, we're going to have an opposite pressure pushing forward, which we always have. There's always some pressure pushing forward. And what that does is it makes you have pressure behind the lens. And the pressure in the lens is not so bad when the lens is relatively solid, but as soon as the lens is hypermature and becomes liquid, it transmits that pressure as if it was a balloon. And in a balloon, if you go and make a cut in the center, it's going to tear out. The same thing with a hypermature cataract. If you tear it over here, it's going to tear to the peripherally. But if you take a highly viscous elastic OVD and you increase the pressure in front of that capsule to exceed the pressure behind it, it will tear in and not outwards. So here's what I do. I take the case and I put a viscoadaptive in front of the eye. I then paint the white lens with vision blue, and without trying to decrease the pressure in the eye and keeping the viscoadaptive there, I do the capsulorhexis in that space, and it just goes along very easily and doesn't move and comes to the size you want, because if you actually tend to pull the capsule, it will tear inwardly and not outwardly. So then, if those of you who do flax and you think about what happens in flax, it's very similar to when we do hypermature cataracts. In a hypermature cataract, we have this necrotic lens tissue inside the capsule making it liquid. And in a flax case, we have gas. It doesn't matter what you have in the bag to expand it and induce pressure. It's all the same as far as physics goes. Femtoseconds procedures are fantastic, but it's only had very few problems. And I really like to do femto, and we've shown those of us who use it a lot over the past 5 or 6 years, that there are many cases in which femto is really advantageous. Dense cataracts, white cataracts, moderate to severe pseudoexfoliation, fibrotic anterior capsules, myotonic dystrophy patients who have wildly elastic capsules, and posterior polar cataracts, where that layer of cortex it leaves protects you when you do the first part of the cataract, and then can take the cortex out itself gradually. But the problem we've had with femto has been the capsulotomy. When femto first came out, there were reports of 10% of error tears with the femto that eventually fell down to about 1.8%, which is still 8% or 8 times rather higher than we see with phaco. And there's a way around that, and all you have to do is the same thing that we do when we do a hypermature cataract. You take an OVD, and I like Helan GV because of the thin cannula, and you increase the pressure in front of the capsule to be higher than the pressure behind it. And you can see here is this crescent showing the capsule is free, and you can see here it's not free, it's attached. And I take these Haldeperker masket forceps, which have small teeth on the bottom, and I push posteriorly and inwardly, and that will make the capsule only tear in and not outwardly. And you go around where the capsule may not seem to be free, do that, and then it always comes out perfectly fine. And in my last 500 or so since starting to do this, there have been 0 capsular tears. It makes it work much better and makes life much easier. Other things you want to learn is you want to learn to do things like ultimate soft shell technique, where you simply place a thin layer of balanced salt below your OVD, which allows you to do your capsulorhexis in a water-based environment with very low resistance, while the OVD, when it blocks the incision, behaves as if the whole eye is full of OVD. And to put the lens in the eye, You can similarly put the OVD in front of the capsule, inject balanced salt right through it to fill the bag, and inject the lens through the OVD into the bag. That also just makes your procedure a little bit easier for you. And one of my favorites is the try soft shell technique, where I put the OVD, a dispersive against the cornea, and then I put a viscoadaptive to maintain the space and pressurize the eye. And then I put a small layer of balanced salt or a drug with xylocaine and phenylephrine. And then what you can do is you can actually do your cataract surgery in this small space. And when you work in that small space, because it's smaller, you can keep your flow rate down to, let's say, 15 or 20. But the turbulence you get in the capsular bag is the same as if your flow rate was 40, because it's in a smaller volume. And this technique works extremely well with low flow rates and for complex cases like IFIS, all kinds of small pupils, Fuchs dystrophy, posterior polar cataracts, and dense cataracts, because it leaves the OVD layers stationary while you work in this small space. It just makes your cataract surgery easier. As I said, you want to do the cases all the same, but different. So here I'll talk about getting rid of chatter. Chatter is a problem because the more dense the lens and the more you put your foot down on the phaco, what you're doing is most of the energy is dispensed in chatter, in the phaco just vibrating and not doing anything. So you'd like to actually spread the frequency of your pulses out as you make their intensity more dense. So instead of having a pattern like this, we have pulse, pulse, pulse. And what you do is as you go along and you deepen the pulse and make the power higher, you want to spread them out a bit further. And if you do that, you can set it on your machine so that it just makes the whole cataract surgery smoother. And when you do a more dense lens, you're not using that much more energy. You're just hitting sharper punches into the lens to break it up. And you can set it in various ways. So you either increase the power, keep it constant, or decrease it. And when you do that, you have varying pulses from this when your foot pedal is at the top to these kind when your pedal is at the bottom. And what you typically do with this kind of a setting on your phaco machine is you bounce your foot. So as you bounce your foot, when your foot goes down, you're breaking the hard pieces of lens. And when your foot comes up, you're eating the pieces. And so, and you watch the nucleus rotate into the phaco, and it just makes the surgery much easier. So how you set this on a machine is simple. I first set it on the Infinity machine, and you take these boxes and you set it so as the power goes up in the axial pulses, the time it's on goes down. Then you have an off time in between. So there's an interval where you don't get any burning of the wound because the power is off for a second. And it makes it very smooth and easy to use. You can do it for torsional too, but it's not effective as much for torsional. What it does when you do this is you don't need a bunch of boxes here. You need the chop setting and the cortex setting, because depressing your foot pedal different amounts will change how your phaco works. You don't need all different settings to keep pushing buttons on the machine. It makes it easier. So here it is on the Infinity machine. So you can see the power goes up, the time goes down as the power goes up with an interval pulse. And I have it on Oslo Custom Pulse. And then here, I also push the intelligent IP button so that as the vacuum reaches near the apex, then it's going to hit a few hard pulses to free the nucleus so you don't get any burns also. And it makes it work very well. You can do this on every machine. Here is how it's set on the Centurion. Again, you just turn the pulses like this so it goes from 0 to 95, and then it goes from 80 to 15 the same way. You don't need to change it for torsional. You can leave it on constantly for torsional. If you use a signature or white star or any of the variations, you have to go in and program it yourself. So you go to the program, you push the settings. On the settings screen, you push variable white star. And on the white star one, what it does is as you depress the pedal, in this machine, it breaks the pedal down into quadrants of pedal depression. So you set each one where it's on more here, less, less, less. So when the pedal goes to the bottom, the off time is longer. And so it makes the same effect as the other one does. And it's the same thing with BNL. All the machines can do this. These are the IA settings. So you can easily look at your machine or do it with your company representative to show you how to set it so that the machine works better. So my usual settings are for the flow rate. The higher the flow rate, the greater the turbulence, and the quicker you wash out the OVDs. And when you do that, you get more endothelial damage. So I generally use a flow rate of 30 to 33, but I lower it to like 15 in complex cases with my try-soft shell technique, so I keep the flow in a very confined space. Resistance varies, and it's the resistance of the aspirate that you can't set. And the vacuum limit, I don't raise to more than 300 to 330 because in a peristaltic machine, the machines I like to use, it doesn't go up very high anyway. If you watch your phaco as you're doing it, most of the time, the vacuum that's actually operative is about 100 or less and rarely goes to 300 unless you're holding a dense piece of nucleus. And I use continuously varied pulse in every case that I use because it just makes the surgery easier. And if you do this, you can always go back and you can change in your machine how you tilt the boxes to change the variable pulse to what you're happy with and how dense the cataracts you normally deal with are. So like I said, what I want my machine to do is to run automatically like a fine car, so I can just push the gas pedal further for more dense cataracts and the machine will adjust everything else. So I use continuously variable pulse and not multiple settings. I hydrodissect much more than you generally think you have to. This, I think, is critical. One of the mistakes people make is to not hydrodissect enough. If you first accept that it's more stable to do your cataract surgery if you impale the nucleus on the phaco tip and then push against the phaco when you're chopping and not against the capsule, if you hydrodissect until the lens is really free and rotates freely, then you hold it against your phaco tip. It makes the surgery much simpler and there's a lot less stress on the capsule. And so I always try to support the nucleus on the phaco tip by impaling it. And if you understand how your machine works and your settings, you can actually make it much easier for you to do all your cataract surgery. So then let me talk about cracking a bit. There was a whole big thing in the 90s when people started to crack and to chop, and all these people went through different aspirations and different ideas of how they're going to crack. And I came up with my own, which really is not different from others. It's just different conceptually. And I'm going to show you that because I think conceptually is important. So what I want to do is take the phaco and I want to bury it in the nucleus. And when I bury it in the nucleus, it's going to be a bit to the right if I'm holding the phaco in the right hand and just past the very center of the lens in all directions, vertically, horizontally, and to the side. And then I don't want to chop out to the periphery because then it's not as safe. I want to only chop in the part of the lens that I can see. So then what you do is you take it across as if you're cutting a piece of bread. So you regard this as if the phaco machine is stabilizing the loaf of bread. Then you take the chopper and you slice across. If the nucleus is dense, it will crack in half when you get to about here, just near the phaco tip. If nucleus is soft, you'll have to go and chop and slice from rexus to rexus until it's free, then you pull it apart. And when you do that, then the case becomes easy. You rotate and do it again, and it becomes very simple. There are a few things that I would suggest that you use, depending what you have now. I really like this cannula because it's a small cannula and you can inject small volumes of fluid to achieve the same results that people often achieve with large volumes of aggressive dissection. You don't want to hydrodissect aggressively, you just want to do it in multiple places with low volumes to work. So I hydrodissect by taking this cannula, putting it under the capsule and running it along the edge of the capsule as I hydrodissect with cortical cleaving hydrosection to get the capsule to be free from the nucleus. And then I also use this chopper. The best thing Nickerman ever made was his quick chopper. It has this long flat blade so you can pull the pieces of nucleus apart and the corners are sharpened so you can cut it into a dense nucleus. And I take the chopper and I insert it inside the capsular rexus and run it down to the opposite one so it works. And here's a simple case showing you how that works. And you just chop it, pull the pieces apart, rotate the lens, just hold the edge, chop it again, and it comes apart. And just do this again and again. And it makes it really quite simple. And you can chop the lens up and go ahead and do it. So the other thing I want to talk about is when you do your capsular rexus. Strangely enough, you know, I'd done things like in the 80s in OVDs and various things, and no one seemed to care. And I became somewhat well known when I published this paper in 1992, and it talked about physics that we all learned from our mothers and how to cut a piece of paper. And basically, you don't want to tear the capsule by stretching it, because when you stretch it, it will tear randomly anywhere in the capsule. you want to fold the capsule over and tear it by shearing, which is how you cut paper with scissors when you shear across the strength of the paper. And so also, how big should your rhexis be when you do that? Well, here I am making a rhexis manually, and here's a femto one. And you know, the capsulorhexis is really the life ring of your surgery. So if all goes wrong, what will rescue you in the end is a rhexis, because you can capture the lens inside the capsulorhexis. So the question is, how big should your rhexis be? And the answer is about 4.7 millimeters. When I hear people saying they make a bigger rhexis because it's easier, it might be a little bit easier for some parts of the surgery, but it tends to make your patient harder later. And let me show you why that happens. If you look at math, which always helps us if you actually pay attention, and you put in a 6 millimeter lens, if you have to capture that 6 millimeter lens, the black ring, into a capsulorhexis, the perimeter of the lens is 18.8 millimeters. And then you say, let's put the capsulorhexis, which is the oval, because it will become oval around that lens. So here's the rhexis, and the perimeter should be about 14.9 millimeters to give you an oval that will hold this lens with stability. If the perimeter is bigger and the capsule is at all elastic, it will flop out of the capsule and not stay stable. So let's say you make the rhexis 4.7 millimeters. The perimeter is going to be 14.8, which is very close to the ideal of 14.9. If you make the capsulorhexis 5, the perimeter is 15.7, which starts to approach this green circle and makes the capsule unstable in terms of being able to grasp the lens if the capsule is at all elastic. If it's not elastic, you can make it bigger, and you can make the capsulorhexis up to 5.2, and it will still hold it. So in hypermature cataracts with a not elastic capsule, you can get away usually with 5.2. But otherwise, I suggest if you're doing most cataract cases, try to keep your rhexis to about 4.7 millimeters, because it just ends up that the case is easier. And if you do break the capsule, you can easily capture the lens, and it's very, very stable, and the patient is fine afterwards. It was Howard Gimble who first talked to us about capturing a lens in this drawing from one of his illustrations and papers. And it's been a very useful technique to save me in complicated cases where I may have broken the capsule at some point or another. So then the last thing I want to talk to you about is the little tear out rescue thing. So the question is, what's he actually doing over here? So you see that the capsule is going out. So he takes it and he pushes posteriorly and pulls towards the center. Well, Jim Gills taught us when he was active in the 80s and 90s, not to fold the capsule over, but to push it posteriorly and pull towards the center. And so what he's doing here, he's doing a Jim Gill style capsulorhexis, which makes the capsule tear towards the center, as long as you have OVD in front of it, inducing some pressure. And of course, this always works. It's a very good technique to learn. So in summary, suppose you want to do your cases more efficiently and quicker, and you think you've got all this down and you're an expert on phaco machines. But the point is, don't hurry. Get quicker by getting better. As you learn to do each of the steps in phaco more perfectly, you'll find you get quicker on your own without having to rush anything or not do it as well. Work on one aspect of your surgery at a time. So for example, if you want to work on capsulorhexis, decide that day in your number of X cases, whatever it is, 10, 12, 15, you're going to do every case a little bit better capsulorhexis. And as you do that, by the end of that day, you'll be better at doing a capsulorhexis. And work on decreasing turnover time. One thing that always annoyed me in the operating rooms is when the nurses would go for coffee after every second case and waste half an hour. So if you can make some incentive for your staff to do things a bit quicker and not waste time, you'll find that you can do very well. And our turnover time is now about a minute from one case to the next, and it makes things very pleasant and very easy. Minimize how much paper and computer writing you do from case to case. Have things ready so you just have to go to the next case and not have to spend a lot of time writing on a computer screen or signing forms. Avoid delays and bring it to the operating room. We have some kind of a call thing. You push a button, and 3 minutes before you want the patient to come in, or 4, they ask the patient to get up, because that's when the patient wants to go to the bathroom every single time. And you stop having that if you warn them in advance. And dilate your patients. I love to use intracameral xylocaine with phenylephrine, because first cases in the morning, IFIS cases, numerous cases with small pupils, all femto cases, the pupils come down from femtos, are made much easier diffuse intracameral dilation. These are all different things. And as I said, work on one of these things at a time. And as you do that, you'll find your cases get easier, things get smoother. You understand your machine better. You got your settings done. You change your settings a bit and try it a few times, change a bit more, and stop worrying about it. Just try to keep making your operations slowly more efficient and better. And you'll see that your times come down, your complication rates go down, and you understand your machine better, and things work well. So it is a complicated thing. It takes time to teach residents and fellows. They have to understand all the steps. Every step is much more complicated than it looks when people try it the first time. One of the tricks with teaching residents is to have them do the last parts of surgery first, just to do a little bit so they get the idea of working in the eye, and then to back up as they go along and get better. And those are my comments. Thank you very much for having me. And now we get to the good part of this cases and having to see complicated cases. Thanks a lot.
Thank you, Prof. Arsinov. I think it's a very important lecture. We are very enlightened, I think, and we think it is important for all of us to know the device that we are dealing with and knowing what we must do in complicated case. Thank you. Dr. Ahmed will do a video session about interesting case of phacoemulsification. How are
Thank
you?
you very much.
Okay. It's honor to have you, to welcome you. Dr. Aik Ahmed, please, the time is yours. For your CV, Dr. Ahmed has become world-renowned for his skill and groundbreaking work in the diagnosis and surgical treatment of highly complex eye disease complication. Dr. Ahmed has received research grant and has designed innovative glaucoma diamond scalpel for surgery, microsurgical instrumentation, and device implants and technique for the management of dislocated cataract, eyes reconstruction, and glaucoma implant device. He has published widely and given over 750 scientific presentations thus far in his career, including 31 visiting professor lectures around the world. And now Dr. Ahmed is currently assistant professor at the Department of Ophthalmology and Vision Sciences, University of Toronto. Thank you, Dr. Ahmed. Time is yours.
Assalamualaikum. Thanks so much for the invitation here to speak at the University Airlangga, and I'm pleasure to be here with one of my mentors, Steve Arshinoff. Steve was one of the reasons why I pursued a career in ophthalmology. I was initially interested in orthopedic surgery, and Steve knows that he convinced me in my second year of medical school to pursue the best specialty in surgery, which is ophthalmology. So I'm always indebted to Steve, and I always enjoy hearing him and working with him. We're in the same city, so we often share some common cases and common stories, and we're always fighting the battle. I think both of us are a little bit of outsiders. We're not necessarily in the establishment. At least I think, I'm sure I'm not. I'm sure Steve feels he's not part of the establishment, but you don't have to be part of the establishment to affect change. In fact, often change actually starts outside the establishment, and eventually the establishment often adopts the change, and then you're already moving on to something else. And Steve is an example of this within our city, within our country, and internationally as well, as a pioneer and a maverick. And so it's great to be here with him. I enjoyed the presentations today. My job is to present some interesting cases. I hope that you'll find them interesting. I always, I'm concerned. I hope this will be of interest to you, but I picked some cases that I hope will help to address some complexities. I'll start off with a little bit of more routine cases, and maybe we'll move into more complex cases. These are some of my disclosures, and this is our city. We're all, in the middle of the pandemic, so it's been a challenge. I hope everybody stays safe. Inshallah, we will be together soon as one, and it brings us together. So let me talk about extreme cases, simple approaches. Those that know me really know when I'm in the OR, it's a pretty simple approach that we look to dealing with these cases. It always starts off with making sure we have the right attitude. going in with an air of confidence, but not being overly cocky, and going in well prepared and ensuring that we're motivated for the best outcomes and doing it for the right reason. We often ask ourselves, why do we do things? Well, we do things because they're there. We do things because we can, and we do things because others can't. And that's kind of the drive of humanity. And I always love, Muhammad Ali's quote, impossible is nothing, because so many times we're told it's impossible. And sometimes, yes, we are humbled by our own inadequacies. But I always say, let's make a great effort and be well prepared to serve our patients. I always think of complex situations as situations you can break down into simple concepts. I'm not an overly sophisticated thinker. Steve Arsenault is a sophisticated thinker, as you can see. I'm a pretty, boots and straps, low to the ground, trench worker, working on the field, working on the ground, and just finding ways to just solve problems. I'm lucky enough to be, blessed to be able to use my hands to do the work I do. But really, each of these complex problems can be simplified. Now, often it's important to push ourselves and not be comfortable. Operating in environments, whatever they may be, in situations that are not as comfortable as you can be. It's easy to be comfortable, and we all have a human tendency to be comfortable, but I think you have to live a little bit uncomfortably to really push the limits and know what you can do. I actually have this case I want to first start off from Steve Arsenault. This is a case he shared with me recently. This is a femto case he did, and you can see how effective the femto is in this case here. And I want to thank Steve for his great technique of couching using phaco tips. I'm just kidding. That was not Steve Arsenault operating. That was one of our residents operating. And of course, complications happen. Now, when we're here today, the goal really is to try to, move people forward, right? We're not trying to make everybody into a, superhuman surgeon. We're trying to move you all forward to deal with more complex situations. And sometimes it's just an attitude. Sometimes it's a cognitive approach in how you deal with something. And sometimes it's physical skills. I've evolved in my settings, and I always enjoy looking at phaco-dynamics, and you can see where I am with our current technologies, where we have really dropped our infusion. And of course, as you heard earlier on the Centurion, we can set our IOP values. I'm operating at very low pressures, but yet operating at fairly high vacuum and aspiration levels with effective control in my hands of pulsing longitudinal phaco as well as using torsional phaco. I do like to differentiate chopping versus quadrant removal. There's a value in holdability when we're trying to chop, as we see here. Now, actually, I do want to mention one thing. When I do with dense cataracts, I have to say I do like to sculpt down to get a little bit deeper and then bury my tip. Notice that we're using only longitudinal phaco here to drive the needle into the lens substance and do a partial crack and then crack the back half there to ensure we have two heminuclei. Again, we're on chop settings, bury that tip, look how high the vacuum is, and only longitudinal phaco is used to really get a good purchase. This is basically all about holdability, all about occlusion, and not about followability necessarily. Now we're going to quadrant removal. Torsional phaco is very effective for followability, as you see effectiveness here. And that's where we want to use torsional phaco and increase our flow rate while we don't need as high a vacuum. Again, going back to chop settings, high vacuum, flow rate that's not as high, quadrant removal, higher flow rate, a little bit lower vacuum, and only torsional phaco. So I do flip back and forth between my chop settings and my quadrant removal, because torsional phaco is not as effective to bury the tip into lens substance. While longitudinal phaco is more effective. It's like driving a nail directly into a piece of wood. And using a chopper, like a vertical chopper like this, I do like to use these in more dense lenses. And so those are just some small pearls in dealing with these dense cataracts. We are lowering our IOP infusion more and more. This is a bit of an older case. This is an aniridia case. Again, I'll just forward it. You can see that because of the poor red reflex, we want to avoid typically vision blue in these cases because the capsules can be very super thin and more fragile, and trypan blue can cause more fragility of the anterior capsule. So we're using a bit of tangential light to see the capsular rhexis to do this aniridia case. But this is a pretty dense cataract. And I'm going to tell you, I do agree that we need to do a good hydrodissection, but I still like to sculpt these lenses. I find if we try to chop these lenses, that the traction on lateral separation is difficult, and it may be hard to get a full thickness crack with a posterior leathery fiber plate left. Femto laser, I think, can be helpful in these cases. I completely agree. And I think can be useful in more moderate to dense lenses Of course, femto is not widely available often, but I do think you don't need to do femto to do a good phaco case. You can see that we're basically bearing and going deeper here with scalp settings. I use a combination of torsional and longitudinal phaco with lower vac and lower flow than I typically do for my chop settings. And we're getting pretty deep. I like to dig really, I like to really phaco deep into the lens substance, just to get to that posterior plate when you start to see the red reflex back here. And we are about 4 needle tips deep. The needle's about 1 millimeter. So, most lenses are at least 4.5, 5 millimeters. And now you can see we're going to bury into that distal part of the nucleus and crack. And so this is like not really a full stop and chop. This is kind of a debulk chop. I do think debulking just helps to allow the crack to propagate with gentle lateral separation. Bimanual rotation is helpful to deal with these dense lenses. Don't be afraid to rotate more and then again embed with high vacuum longitudinal phaco and then crack again. Again, you'll see that I'm again only using longitudinal phaco for this part. I'm using higher vacuum and a bit lower flow rates. But once I get a crack and I bring that quarter nucleus forward through the capsulotomy, I'm going to crack again here because these are somewhat dense lenses. I really move to the quad settings. My quad settings are basically only torsional with a little bit of IP, which gives you a burst of longitudinal at higher vacuum levels, occlusion levels. And again, using more of a followability, higher flow rate for those settings as well. So I want to just show those cases. Posterior polar cataracts are always a bit of a challenge because these cases often have very thin, if not deficient, posterior capsule. Just touching the posterior capsule or any pressure on the posterior capsule can be difficult. These are remnants of the hyaloid artery and are often bilateral and congenital. And often there are remnants that are left also within the anterior hyaloid, as you'll see. These are often younger patients. Fortunately, these are relatively soft lenses, and therefore employing a technique where we remove the endonucleus first while leaving the epinucleus is helpful. It is important to get a very good anterior capsulorhexis because that's important because just in case you lose the posterior capsule, we can use the anterior capsule, as Steve mentioned, to do an optic capture of a 3-piece lens if necessary, or a reverse optic capture of a 1-piece lens if necessary. These are somewhat younger patients, so we basically take advantage of the elasticity of the capsule using shearing techniques. If necessary, we can use a stretching technique. And I completely love Steve's paper back from '92 on the mechanics of rhexis. This is a pivotal paper on understanding vectors and different shearing and stretching forces to tear a capsule. I do not do hydrodissection in these cases, but what I do is I call manual cortical disruption. I'm manually using my Chang cannula here, which is my hydrocannula, to just loosen and roughen up the cortex. This will allow cortical removal to be a little bit easier as we remove the cortex, but I don't inject BSS. I don't want that BSS to travel posteriorly and potentially cause a blowout of the posterior capsule. But I do like to do hydrodelineation, which is where we separate the endoepinucleus by placing that cannula tangentially into the mid-peripheral lens. These are soft lenses, so we can literally use the irrigation aspiration handpiece here to remove the endonucleus, aspirating the central nucleus and leaving the epinucleus in place. But you'll see, once we do that, we do see what is a suspicious opening there in that posterior epinuclear and capsule layer there. Some dispersive OVD is helpful to sequester the area to ensure vitreous does not proceed. We don't know if it's open or not. And then continue to segment out the epinucleus, removing here the superior, inferior, temporal, and nasal components before flipping the posterior plate. This ensures that we remove all the lens material before we remove the central, more vulnerable area of the lens material. At the very end, you can see that there's a somewhat phimotic ring on that posterior capsule. Before coming out, very important to put some OVD in. In some ways, this is kind of a reverse soft shell to at least sequester and create space. Dispersive first, followed by cohesive, and then we're going to just continue to evaluate here. You can see that there's this phimotic ring. I'm going to decide to put an IOL in the capsular bag. It's a 1-piece lens here. And I do this now because I'm going to have to manipulate the posterior capsule, and I just find it's easier to put the lens in. I can work under the lens here, and therefore I have the safety of a lens in place now if something goes wrong. This is using a micro scissor to cut the posterior capsule. There's an opening in the posterior capsule you can see, and this phimotic ring present here. This is actually a posterior polar plus because you can see there's these lamellar dots on the anterior hyaloid. Doing a posterior rexus is something that may appear intimidating, but really is very similar to doing an anterior capsular rexus. This is really just using the same type of shearing and stretching forces of tearing a capsule, but the capsule is much thinner, especially in posterior polar cataracts. So frequent regrasps, understanding vector forces to ensure the tear is in the right direction, and making sure the rexus is going to be about 4.5 millimeters is reasonable here, because often we will capture the lens within that posterior capsular rexus, especially in pediatric eyes, which this patient is. You can see that there's these opacities that we're removing here. And now I got to make a decision here. These are opacities on the anterior hyaloid, but I don't need to break the anterior hyaloid to remove these opacities. I can vacuum these here. One of the most important pieces of equipment on my tray is this 27 gauge cannula. This is a disposable or could be reusable cannula, which we use to do all kinds of things like aspirating lens material in the setting of a posterior capsular break, or in this case, vacuuming the anterior hyaloid. If you want to invest in a piece of equipment, don't invest in femto laser, invest in a nice 27 gauge cannula. You can do a lot with it. You can see how we're basically vacuuming the anterior hyaloid, these little lamellar dots that are present that are remnants from the hyaloid artery bundle, and basically just aspirating. Now, I could have gone and done a vitrectomy here, but there's certainly benefit in not breaking the anterior hyaloid for many reasons, including retina and macular edema. Now we have removed enough of the opacity here. I think we have a good clearance here. We can then prolapse the optic through the posterior capsular rexus. This can be done with a 3-piece or a 1-piece lens. And the benefit of doing this will prevent PCO or prevent proliferation of lens epithelial cells on the anterior hyaloid, which occurs in congenital cataracts more so. This is my technique, by the way, for those of you who do congenital cataract surgery, whether the patient is 1-year-old, 2-year-old, 4 or 5 years old. I don't do a vitrectomy. I just do an anterior and a posterior capsular rexus. I put the IOL in the bag, and I prolapse the optic of the lens through the posterior capsular rexus. This is a posterior optic buttonhole described by many folks, including Manny Pachi and others, that really hold the lens in place nicely and prevent proliferation of lens epithelial cells over the anterior hyaloid. Let me switch over to a very small eye. This is an eye that's a nanophthalmic eye. You can see the anterior chamber is very shallow with PAS and a very high pressure on maximum meds. The endothelial cell density is also reduced. And this is a 16.4 millimeter eyes. These are quite routine in our practice. We get these eyes all the time, and we have to deal with these difficult situations as a glaucoma specialist. The AC depth is 1.4. This is a very small eye. And you can see on the B scan, the retinochoroidal scleral thickness is greater than 2.5 millimeters. This patient has a thickened choroid. This patient actually is a malignant glaucoma. Thickened choroid, vitreous compression, a small anterior segment resulting in a shallowing of the anterior chamber. Don't call this aqueous misdirection. This is not the right term to use. And Harry Quigley's work on malignant glaucoma, I think, is really vital in understanding the pathogenesis and the treatment of this disorder, which can happen spontaneously after laser or can happen after filtering surgery or even cataract surgery. But we've got to manage the spaces in this patient here. What about IOL calculations? Well, simply using the older formulas are not good enough. Although we know that AC depth and ELP, effective lens position, are correlated to axial length, this is not true for the extreme axial lens. In fact, people who have small eyes may actually have a deeper AC than average eyes, or have average AC depths as average eyes. Same thing on the other extreme. So use modern generation formulas. The Barrett and Olsen, in my opinion, are the top formulas for these very small eyes. But you can see the IOL powers required for these eyes are very difficult. Do not use piggyback lenses. I really will strongly discourage you from doing this because there's not enough room and you will run into trouble with these issues. Instead, use a high-powered foldable lens, like a single piece lens. The Alcon SA60 is commonly available up to 40 diopters, and the Human Optics hydrophilic lens is available in up to 60 diopters. And you can see that you can go quite high and you can work through a small incision and the benefits of a foldable lens. It's helpful also to do gonioscopy intraoperatively. Yes, that's the angle, and it's good and helpful to release synechia if necessary by using different techniques. We typically use a micrograsper to release the PAS because simply removing the lens and angle closure isn't enough. Angle closure is common around the world and certainly in Indonesia. Cataract surgery is very effective at solving these problems, but if we don't release the PAS, it's a problem. This is that same eye, 10 millimeter white to white, 1.4 AC depth, 16.4 axial length with a very shallow chamber. These are all the principles here. First of all, mannitol. Mannitol, very helpful. 1 gram per kilogram, give it 45 minutes pre, and then proceed with surgery. If necessary, do a general anesthetic. I typically do not block these patients, but topical is reasonable or general. I do a sterile cut down when the eyes are less than 18 millimeters. This is important to relieve effusions that may be present and prevent postoperative effusions, which can be very difficult and recalcitrant to medical therapy. I'm typically using here a diamond blade. This is 4 millimeters or 5 millimeters back from the limbus, cutting right down. So we go right down to the choroid, we relieve some fluid, and we keep this open. This will allow the equilibration of supraciliary pressure, which can increase in these eyes because of the difficulty, because of the thick sclera and the difficulty in equalizing the pressure. This can cause effusions, and therefore this will allow a relief valve, so to speak. I typically make a little punch opening here and leave it open. If there was a large effusion, I would do a 2-quadrant cut down. And although I argue with my colleagues, I do like to do this routinely because we do get in trouble with these very small eyes, even though it may be more prophylactic in nature. I leave it open at the end of the case here, and you'll see me at the end here. Eyes that are less than 18 millimeters, that's what I do, or if there's an effusion present. More than 18 millimeters with modern day phaco is probably not necessary. I don't typically do it routinely. You may say, Ike, why not do a pars plana tap? Well, the problem is in these eyes, we don't know where the ora serrata is. It could be 2 to 2.5 millimeters back from the limbus. So where do you enter in the pars plana? These are not normal eyes. So I typically avoid making an incision through the pars plana. If you have to and you're forced to, go very anterior, like 2 millimeters, but be aware of hitting the lens. This is where a super viscous cohesive agent like Helon 5 can be helpful to keep the chamber. But I'm working under positive pressure, and working under small incisions is helpful with the right OVD. Fortunately, this patient has a fairly soft lens. We do a capsulorhexis. We'll do a gentle hydro. Do not allow for iris prolapse or shallowing of the chamber. Any shallowing of the chamber can result in an effusion or malignant glaucoma that can occur, and this can lead to extreme positive pressure. So at all costs, do not let this chamber shallow. After removal of the lens material, inject viscoelastic in the eye to counterbalance the positive pressure that is present in this eye and prevent as well. And come out very slowly, and don't come out on position 1. Don't irrigate when you come out. All that does is cause more turbulence, loss of OVD, and potential for shallowing of the chamber when you come out. Again, coming out again here, we come out very slowly after the cortical removal. We'll put the IOL in, and we'll then typically suture that incision right away. My second or multiple pearl scissors in these small eyes, in my rule, it's less than 20 millimeters. I am doing what's called an iridozonular hyaloid vitrectomy. Anterior approach is typical here in these small eyes. Vitreous cutter is used to make a moderate sized PI. And then we place the cutter through the PI and cut the very small area of zonules and peripheral capsule and anterior hyaloid and do a small vitrectomy. Why? A unicameral eye is the definitive treatment to treat malignant glaucoma. These patients don't need a complete vitrectomy. These patients really need a unicameral eye, and doing this allows for the equilibration of pressure between the anterior and the posterior compartments of the eye to relieve the positive pressure built up from the choroid being expanded, plus or minus effusions, and the vitreous being compressed and losing its conductivity. You can see once I broke the anterior hyaloid, the chamber deepens up immensely, massively. Look, just by doing the small limited hyaloidectomy with vitrectomy, we have a very deep chamber now. At this point in time, we can then do some release of the PAS, and we can use a pair of forceps to do this. I like to use an intraoperative gonimer, as I showed, and we basically can remove the synechia from the eye here. And postoperatively, you can see 1 day post-op, we're fortunate enough that we can basically have a nice, relatively clear cornea despite the endothelial reduction with a deep chamber and normalization of the IOP. So that's nanophthalmic and small eyes and angle closure. Notice I suture my incisions in these eyes. We don't want to have any shallowing of the chamber after surgery. So let's deal with zonular problems. These are one of my favorite difficult cases to deal with. Sometimes they're mild, sometimes they're severe. You know, have the right tools in your toolbox. And I think a capsular tension ring is very helpful for mild cases. You can see in this case, you can see some stria and some folds on the capsule during the initiation and performance of the capsulorhexis. In these cases, I typically do some early viscodissection with a cohesive viscoelastic to create space. And this will allow me to separate the cortex from the capsule to avoid trapping the cortex behind the capsular tension ring, which when placed early here, supports the capsular bag, prevents collapse of the capsule, prevents fluid misdirection syndrome, and prevents nuclear particles from furthering posteriorly, as well as supporting the zonule and the capsular bag. And once we have this in place, we're injecting it with a ring, with an injector, the ring. We have the bag expanded and centralized, and phacoemulsification can occur normally. A bit of hydrodissection with a wave, hydrodelineation is nice in a softer lens, and we are fine to then remove the lens, keep the chamber formed when coming out to prevent vitreous prolapse, and the IOL goes in. I put a toric in this case, and you can see that we are in good position. In more advanced cases, it's helpful to have modified CTR or the capsular tension segment, which has an additional eyelet that can be sutured to the sclera. I do these cases when we are have more profound zonulopathy here. And here's an example using an iris hook with a CTS holding the capsular bag in place. When I need to suture devices in, I typically use the CV870 Gore-Tex. This is the ideal suture, and in our experience over 12 plus years, we have not seen breakage. With 10-0 and 9-0 Prolene, we sometimes do see breakage. An iris or capsular retractor can be helpful for temporary support of the capsular bag. I like the MSD retractors because they support the capsular bag at the capsular equator. This is a patient, a younger patient you can see with Marfan syndrome and a sublux lens. This patient has about 3.5 diopters of width through rule astigmatism. I always sit temporally. That's why you see my approach here. And we're going to perform the capsular rhexis. I typically use a more super viscous agent, again, higher viscosity agent. And we'll start a capsular rhexis. Now, the bag is not round. So don't make the capsular rhexis round. Follow the capsular bag contour by making the capsular rhexis to follow the capsular bag. And this is going to be a smaller capsular rhexis because we have a smaller lens. But the bag and the capsule can expand 1.5 times its size easily. And so we'll see once we basically expand the bag that this capsular rhexis will be perfectly sized. But we have to basically eyeball a bit here, and we need to basically make it a bit ovalized. Don't make it too big either, because otherwise you'll lose the capsule shelf that is so vital to hold the bag in place during the lens removal. These are nicely showing the MST retractors that support the capsular equator. And you can already see the capsular rhexis becoming more round in nature. We remove the lens material, put a CTR in, and you can see CTR is not going to be enough here. So we're going to use the capsular tension segment here to be placed in the eye. We're placing it into the anterior chamber, and then we will place a 25 gauge needle through a scleral incision. The scleral incision should be at least 2.5 millimeters back from the limbus. Place the needle through the eyelet. This is the Gore-Tex suture needle through the eyelet of the CTS, and this will then allow the CTS to be supported by the sclera. Maneuvering the CTS back into the capsular bag, we will then make our next pass here, and this will basically be that second pass of the Gore-Tex suture through that docking approach. We then tie the suture, place the toric lens in the capsular bag. As you can see, they're rotated in position, and then tie. Look at the capsular rhexis now, right? That's about I don't know, 4.5, 5 maybe in some meridians. So, that's the lesson in doing these capsular rhexis. And you can see we have really a beautiful position lens. This outcome should be no different than a routine phaco, which is what our goal is. Again, complexity, simplicity multiplied. Simple steps to deal with complex problems. Removing the OVD manually to avoid more turbulence in the eye. And that's how we can do that. Let me just switch over to dealing with more iris problems here, because we can often combine phaco dealing with more complex iris reconstructions, which can be very gratifying. This is the case of iris trauma. I typically use 10-0 polypropylene suture, and I use micro instruments like from MST, micro graspers and micro tying forceps and micro scissors that were designed many years ago to allow us to manipulate in the eye here. There are different ways to tie the suture. I recommend going to our YouTube channel and many different YouTube videos and iTunes videos that can show you the technique. These are approaches that can be used. I use what's called the McOmmet approach. I'll just kind of go right to the video here and just kind of to show you the different things we can do. Now, when we do suture these, this is really the art and the science of surgery. Visualizing how we want to close this iris and taking advantage of the elasticity of the iris, even though we're missing large amounts of iris in this case. And even though we have about almost 2.5 clock hours of iris missing, we typically can still do this in a way that allows us to close the defect with reasonable cosmesis. If not, we use a prosthesis. A couple of tips: make the incisions farther apart. This is the CIF4 needle I was talking about on the tenoproline. This is the long needle, and this needle allows us to pass it through 2 incisions that are made about 3 clock hours apart, docking the needle as it comes out. Now, I don't have time to go through all the different techniques, but what I do is I externalize both ends of the suture out through the main incision. We have a long end and a short end, and then we will basically use a micro tying forceps to tie around outside the eye, and we push the suture in the eye. This is the modified mechanical, or as some have called, McAhmed approach. It's very simple to do, and it allows us to control not looping outside the eye while bringing it into the eye by sliding it in. And we can then, close the defect here by placing the micro tying forceps back into the eye and doing this. And we'll do this multiple times. I like to lock the knot. Others have done it without locking the knot, but I like to lock the knot. And then we'll basically cut the suture. And we're going to go through all of this, and we can basically then close the defect. It's very important to try to maintain a round central pupil. This is important for our patients in terms of cosmetic benefit and taking the time to do the surgery. One thing that I hope that people notice is that, and I think Steve also mentioned this, is like, when we do the surgery, we're doing it efficiently. We're not rushing. I mean, this is like, although I listen to rock music when I'm operating, this is like a nice classical musical piece with building it up with the right pace to manage it. And you can see post-operatively these pictures here. It's really gratifying to close these defects. This is just a view of ROR, lots of views, and I hope that we can open up to observers. We always get lots of visitors in ROR from around the world. It's always beautiful to have people visiting. This patient visited us from Hawaii. She has a dilated atonic pupil with cataract. In this case, we are going to remove the cataract, and she was very keen to receive a multifocal lens. I don't do a ton of multifocal lenses, but for the motivated patient and the right patient, I do. And she had worn multifocal contacts, so I'm putting in a pupil-independent, diffractive, multifocal lens, toric designed. And this is a bit risky because I'm going to have to repair the pupil here. The pupil is dilated and atonic. So if she doesn't like the procedure, I'm going to have to go back and undo everything. But those are the risks we take with the right patients. And the patient was very reasonable, I thought, even though she was American. And you can see basically, just kidding. So you can see basically the pupil is widely dilated. I'm going to do my most favorite technique here, which is the pupillary cerclage, using the same curved needle, a tenopolypropylene suture. And I'm going to really strongly urge us all to really do bimanual maneuvers in the eye. I'm using my left hand here with the microforceps to hold the iris while the needle is being passed. In fact, the forceps are doing more work than the needle. The needle is hard to maneuver in the eye, but the forceps can be maneuvered, and we're going to basically pass the needle through one quadrant, and using the double-armed suture, we're going to go through the other quadrant. But in this case, I'm going to use my left hand to hold the needle, while my right hand is using the forceps, and I'm using different grips of my hand, because we have to remember that we want to hold instruments flat in the incision so we don't open and gape the incision. I typically like an overhand grip. I do not like the pen grip. Steve's absolutely right. I hate the pen grip. But most surgeons hold the phaco tip like a pen. And that's completely poorly done ergonomically. The late Alan Crandall also was really strong with those hand positions. And I espouse those principles as folks have talked about. And so we go all the way around. We tie the suture using the McAhmed approach, and you get about a 3.5 millimeter pupil size is ideal. The right balance between protection from photophobia, cosmesis benefit, but still allowing visualization of the retina. And yes, you can view the retina. Don't worry. If you're really worried, you can cut the suture. But this allows for the ideal balance here and cosmesis for this patient. You can see postoperatively, she's wearing a multifocal contact in the left eye, and the right eye she's seeing really well with her trifocal multifocal lens. And she was happy with it. This is just a view. I recommend strongly to really try to do the best you can to watch your videos and review videos as well. This is the case of a white cataract, a traumatic cataract with iridodialysis and atonic pupil. And so we have lots of things to worry about in this case. We're going to use some iris hooks to pull the iris away after we do sneakiolysis from the capsule. And when I do this, I like to put Vision Blue under viscoelastic, typically under cohesive. This allows the Vision Blue to be placed where it needs to. It prevents the Vision Blue from going posteriorly, and it allows me to place it where I need to. If I put it before I did this, then it wouldn't stain the entire capsular bag where I wanted it to, limited by the pupil, for example. I go in with a 27 gauge needle and aspirate any liquefied cortex in these white cataracts, and then carefully do the capsular rhexis. In this case, the zonules weren't bad. If there's a capsule plaque present, it's important to try to go around it if you can. If you have to go through it, this is very difficult, and one has to potentially use scissors. This is another advantage of femtolaser, however. If you can do this, we would have to do it in 2 steps, right? Because the iris is blocking it, but you can release the iris and then bring the patient to the femto and do the femto capsulotomy. A bit of work. I don't know if it's worth it, but that's one option too. And again, these are relatively softer lenses, and so we can basically aspirate here with our irrigation aspiration. IOL goes in, and then we can basically manage the iris. And this is basically using straight needles, tenoproline suture needles, using horizontal mattress sutures to place these through the peripheral iris. And so this allows me the way that we are. This allows me to really go through the peripheral iris and reapproximate the iris to the iris root. This is about a millimeter back from the limbus, and we make these about 2 clock hours apart to really span the iris. Make sure that the passes are made farther apart when you go outside the eye. The circumference of the iris, of course, is shorter than the circumference on the sclera. So you see the distance between the passes are farther apart. You got to go about 1.3 times the distance here based on the circumference here. Tie the knot in a slip knot. This allows you to adjust the tension. And I'm going to paste another 2 next to the first pass. There's 1 and there's 2nd there. This allows it to be placed there. And then I also, by the way, have to repair the pupil. Removing it from the angle here, you can see it's fairly distensible. And I won't go through it again, but we're going to do a pupillary cerclage all the way around again. So a lot of work. One of the things, by the way, you need to do is have good stamina. I was watching the Muhammad Ali, Joe Frazier, and Muhammad Ali, George Foreman fights this morning while I was working out. Those were 15-round bouts, man. Those guys had stamina. They don't make boxers like that anymore, right? Everyone's going for the quick knockout. But with eye surgery and complex surgery, you need stamina and a good chair to sit in. And so we basically can do this. And, these are very rewarding. This is worth 10,000 routine phacos, right? Take the time to do a beautiful case, and the reward is immense because of the special nature and the uniqueness of bringing back not just vision, not just improvement from photophobia and functional, but the cosmetic benefit of having a normal looking eye that is so pivotal to the self-esteem and the wholesomeness of a human being. We don't treat eyeballs. We treat people and human beings. And Allah has given us so much skill and so much ability to do this. I do have to, of course, thank everybody that I work with. I have an amazing team of people to work with. You can't do it without a team. And luckily enough, I've been blessed to work with people who are really incredible people who bring the love and joy to surgery and to help patients. I thank my teachers and my mentors as well. I do thank the invitation here. There's so much more to share. I do like to share, so please visit us on YouTube. Those of you that are on Instagram, those of you that are on Facebook, please connect. This is the way we connect with each other. Inshallah, we'll see each other in person in the future as well. So thanks a lot. Jazakallah khair for inviting me here today. Never been to Indonesia, but hopefully, inshallah, one day soon. Thank you very much.
Thank you, Dr. Ahmed. We saw highly challenging case and great technique in your video. We hope we can learn and implement your approach in the management of our patient. Now we are approaching the question and answer session. There are so many questions from our participant here in Q&A chat box. The first question for Dr. Aik Ahmed from Prof. Gatot Suhendro. What is the best IOL for sulcus fixation? 3-piece IOL with Prolin haptic or 1-piece IOL? And in a patient without anterior capsule support, what is the IOL preferred? That an anterior fixation, iris fixation, or scleral fixation? What?
Well, we should do another talk on IOL fixation in the absence of capsular support. So just very quickly, a sulcus lens should not be a one-piece lens. One-piece lenses are not designed for the sulcus. They should be in the capsular bag or possibly fixated to the anterior capsule opening using a reverse optic capture with the haptics behind the anterior capsule. A three-piece lens is ideal. I typically use the largest diameter lens you can use. Unfortunately, now in modern days, we don't have those 14 millimeter diameter lenses as much anymore. But typically a three-piece lens, PMA haptics, a 10-degree volt is ideal. Typically, I use a hydrophobic lens. Optic sizes are limited again, 6 millimeter optic. Typically, these are 13.5 millimeter diameter lenses. And that's kind of ideal. And if you can optic capture the lens in the anterior capsule, that's ideal. When there's no anterior capsule support present, I go from all kinds of approaches. I do like to use the sclera. I use a double needle Yamane technique with a three-piece lens. I think that's very effective, and I do this a lot. I do suture lenses to the iris as well. If there's no history of uveitis, and the iris is also in good position, because the problem with the Yamane technique is you need to do a good vitrectomy. You need to really go in and ensure that you do a posterior approach, and many surgeons are not comfortable with it. So the iris is a reasonable approach. And then the ACIOL, I don't use a lot. But for a very old patient, I think that you don't want to go back and pass needles and things, I think is reasonable. So there's no one IOL approach that is for everybody. I think it's good to have comfort with all the different approaches, whether it's sclera, whether it's anterior iris with, for example, an artisan lens, or posterior iris with a retroenclavated artisan or an iris sutured lens, sclera fixation with a Yamane or an ACIOL. Those are all potential options.
Okay, thank you, Dr. Ahmed. Maybe next question for Prof. Arsinov. It is from Dinda. How do we know if our viscoelastic is enough filling the anterior chamber, especially when we combine two types of region? And one question too from Prof. Gatot. Excuse me. What is your opinion for white cataract to CCC, double rexis, mini rexis first, and CCC by femtoflex? What is better? Thank you.
Okay, well, the first question was about if you use more than one OVD, how can you tell when you fill the chamber where they are? Well, the truth is, the idea of using two OVDs is to use two that are very different. And when you use two that are physically different, like a very viscous cohesive and a dispersive, you get an interface, and the interface is really obvious. So when you look at it, you can see the interface between them, and you can see exactly where they fill. So it really is not as hard as people think it is before they try it. So that's that question. It really is quite easy to see them, and you can tell how full the chamber is. If you're not sure, you can just, when you come out, touch the eye and see how firm it is, and you can tell if you've filled it with OVD or not. So it really is not as hard as it looks. It's actually quite easy. The second thing is, I don't like the idea of doing a mini rexis first on a hypermature cataract, not because anything is wrong with it. I just think it's a step that you don't need. If you do the femto, or you increase the pressure in front of the anterior capsule so where you see it's concave, you can make the rexis whatever size you like, and it's not a problem in the most hypermature cataracts. The femto does it perfectly. That you then inject the OVD to again depress the anterior capsule, and you can see where the crescent shape appears around the edge of the capsule where it's free, and it's quite easy to see it. And if you do it manually, you can also see when you inject the OVD and you depress the capsule, you can see exactly where it sits, and you can do the capsule really quite easily with Vision Blue. So a lot of these things look harder than they really are. And if the idea is that I tell everyone, you know, my success in life is due to being lazy. If you try to make the physics of devices you use do your work for you, you can do it relatively simply, and it works quite well. And so I think it's not that hard. Just use the right OVDs, try to get a selection of OVDs in your OR, and you keep the ones that, let's say, a Helon 5 for the more difficult cases. As you saw, Ike used them also in the cases he wanted to flatten the capsule and keep it stable. It just makes it easier. You have to use it first in a number of cases, become accustomed to it. But once you're accustomed to different OVDs, you can mix and match them quite easily. I want to actually compliment Ike. Whenever I watch Ike's videos, Ike came to me when he was a young guy playing football for the University of Toronto football team and determined to go as many athletes that are young into orthopedics. I think the smartest move I made in my career was to twist Ike and tell him I'd beat him up if he didn't go into ophthalmology. He's just way too smart to be hammering hips. And whenever I watch him, he doesn't understand it. I'm an older guy compared to Ike, and I think the greatest success of my career is watching my students do much better than I ever did. And he's also right that both of us have been rebels our entire life. And it's actually quite funny because we're at the university, but we sort of are and aren't, because they don't really like us. We always tell them what they're doing is wrong. And the way you advance things in the world is to be a bit of a rebel and to come with a new idea. And Ike has done that. And of all my students, I think Ike has done it more than anybody else. And he's almost as miserable as I am. He goes there and he says, no, what you're doing is wrong. Do it like this. And I just love your videos, Ike. And I love having you here at the meeting with me and watching you do cases. And the next joy in my life is I just had Ike's son as my student, as I had Ike in the same position. And he wasn't sure he wanted to go into ophthalmology. And I spent about 10 weeks telling him he had to be an ophthalmologist. He's also a brilliant young man, and he will be the next Ike, but probably better than Ike, because he's one more generation better. And it's just, I really enjoy watching your cases, Ike. It's terrific.
Well, Steve, as I said earlier, I wouldn't be here without you and the trailblazing you've done, and it's a real joy, man. You're so kind, and I'm here because of Steve. Steve actually brought me into this meeting, so I followed you in many ways, and so it's your words are kind. You're always going to be my leader, and I'm going to follow you in what you've done. So thank you.
Very well, and I'll send my toughest cases to you because you do them better than I do.
No.
Thank you, Prof. Arsinov. You are famous with your soft cell technique, Prof. And there's one question. Can we change Swiss code by Happy MC for soft cell technique? It is a question.
You can, but it
from
doesn't work
Prof.
as well. I'm fully aware that, viscode in many countries of the world is expensive, and HPMC is a lot cheaper to acquire. I would try for your complicated cases or difficult ones to use things like Viscode and Helon 5. It really makes your life a lot easier. And it's interesting to me because I now, like Ike does, we give lectures online and we're all over the world. And I've given lectures in countries where I was surprised that institution may have a femto and they're talking about their femto cases, which is nothing wrong with that. But when you're paying $1,000 a case to do a femto and you can pay $60 to get Viscode or Helon 5, sometimes the OVD is a better investment. And like Ike said, you can do a lot of cases without the fancy femto if you use your OVDs and other techniques well, you take your time to do it carefully. And there are some cases where I see that before I start, it's going to be a more complex case in terms of what's wrong with the patient's eye, like, broken zonules, this or that, or something. And the femto, it may not have as much variety of what I can do as I can with my hands. And I'll decide in those cases that I'm better off to spend money on OVDs than I am to spend money on the femto or to spend the patient's money. And so I choose to do them manually. And there are some cases I mentioned in which the femto has huge advantages, but there are some cases in which it doesn't. And one of the problems with the studies that we've been seeing around the world not showing any benefit of femto, which is what we had exactly, by the way, in the first days of Phaco, that everyone said it was no better than extra caps, is when you lump all the cases together, you're going to lump in the patients with broken zonules, with all kinds of other problems, the posterior polars and things, with the other ones where some of them benefit from the femto, but some may benefit from a different kind of procedure. And I think it's up to you as a surgeon, to all of us, to look at the case carefully and not look at how much money you're going to get from the case or how much it's going to cost or what you're doing, but what actually is better in this case in your hands. And as you saw with the cases Ike was doing, he spends a lot of time and a lot of effort in doing very little tiny picky things in the eye to make it better. and getting fantastic results. So use your devices for what each device is best for and not for what it's promoted for. And you'll find that you just do better.
Thank you, Prof. Maybe another question for Dr. Diki. Do you have any tips for beginner when facing the moderate hardness of nucleus with high IOP and shallow androchamber? And we need a comment too from Prof. Arsinov and Dr. Ike. Thank you. Please, Dr. Diki.
So moderate cataract with a high pressure and a shallow chamber, I heard. Yeah, so it's kind of the principles I discussed earlier, you know, and I think a lot of these issues are to create enough space. And I'll let Steve talk about the right OVDs because that does help us to create space. I think that in a very small eye, like I said, I like to prepare the eye. I like to control the pressure before surgery with medical means, whether it's acetazolamide or topical drops. Mannitol is helpful. These all help us to go into the eye when the pressure is not high. It's always better to go into the eye when the pressure is normal and go from there. When the patient maybe has, let's say, a very shallow chamber or has angle closure, I prefer not to dilate the patient before surgery. I do what Steve said, which I use intracameral agents, and you know, xylocaine and phenylephrine, for example, are reasonably effective to dilate the pupil along with the right viscoelastic. And then I think it's important, of course, that again, using the right viscoelastic, I typically, you know, use a higher viscosity cohesive agent to create space. And then do your phacoemulsification. This is one area where, again, some people will argue femto may be helpful because you have a shallow chamber, you can get a capsulotomy, you can do your cuts in your lens, and you are already kind of halfway there. Again, I don't think you need to do that, but that can be one benefit. And then really, like I said, I like to look into the angle at the end to make sure the angle is opened up. But you know, those are kind of what I've discussed earlier in my presentation.
Thank you.
I,
How about your opinion, Dr. Diki? Sorry, Prof.
Okay.
Okay, Dr. Indri, thank you. And usually in our place, first we have to control the IOP for Phaco. If the IOP is still above 27, preoperatively, we can administer mannitol intravenous. After that need to be prepared as vitreous tapping or corvitectomy to reduce volume of vitreous, so we can have a space in the anterior chamber. Thank you, Dr. Indri.
Thank you. And Prof. Arsinov, how about your opinion in this case, how we can setting our phaco machine? Or could you show us the setting of your phaco machine in moderate hardness of
Sure.
nucleus?
I actually wouldn't set my phaco machine any differently. I would just depress my foot differently. But what I would do is when I see a patient that has, let's say you get someone who's a +6 or +7 hyperope or +8 comes in for surgery, they may have a narrow angle. They don't always, as Ike said, the anterior chamber can vary with these patients from very deep to very shallow. So I want to assess why their pressure is high. And if they do have angle closure to some degree, I'm going to fix that by doing their cataract surgery. So I don't actually worry so much if their pressure is 25 going into surgery, if I know that their angle is narrow, and by doing their cataract, I'm going to fix that. One thing a bit different from what Ike said, actually, I don't like to do femto on those patients because when you do the capsulotomy with the femto, and then you go back to take out the cap, you may end up with a very shallow chamber because when you have the gas in the bag, it's going to push that capsule forward. And if you didn't get a perfect rhexis with the femto, it's going to be difficult to get access to the bag to make sure that you can tear it freely. So I actually prefer to do those high hyperope cases if the chamber is very shallow manually. And I will inject Helon 5 or IVIS Phaco, two of the most viscous OVDs in the world, to deepen the chamber until it's deep enough that I can get my instruments in freely to do the capsulotomy. And I'll make my capsulotomy like 4.6 or something, not big, so that I have space to work. And I'll do what Ike says. I try to maintain the pressure in these eyes all the time. When you do a highly hyperopic or an anophthalmic eye, you don't want to let the pressure ever go down. And so you keep the pressure high. When you take out your phaco, you inject OVD to maintain the pressure. And then when you finish the case, because they actually aren't that hard, once you've taken out the lens, Often their lens is quite thick, and you find you have lots of room. But I will then do what Ike does and go and take the iris and pull the iris out of the angle. And then often you've also fixed their glaucoma, and they do well. I must tell Ike that I did have one patient of those I had in the past 2 weeks. Funnily enough, I had 6 eyes on each of 2 days, which were more than +7 hyperopes, and varying lengths of eyes, but all very short. And one of them did get a postoperative malignant glaucoma, not very bad. So I went and I did a JAG on him through the iris, through the capsule, and the vitreous as well. And he was fine, but came back a week later, and his chamber started to shallow again. So I had to then get a vitrectomy on him to remove the vitreous, like you said, to make it unicameral. It's a critical thing to remember for these kinds of patients. That really is what makes the difference in the long run. And you have to watch them post-op, more than just like one day after and send them off to resident. You have to actually watch them for a few months and make sure that they're stable. But they're interesting cases, and they do very well.
Thank you, Prof. Arsino. One question more from Dr. Evelyn. What is the best procedure in the case of congenital glaucoma with and cataract? Maybe Dr. Ike want to answer first, and then how?
The best procedure for combination cataract and glaucoma will depend on a number of different things. One is going to be the severity of glaucoma, whether the patient is progressing, the medications the patient is on, and how well they're tolerating, the age of the patient, and other comorbidities. The answer could range from doing phaco alone all the way to doing a combined phacotrabeculectomy. It really depends on all these factors. One factor as well is the diagnosis. Angle closure glaucoma is typically very well managed with phaco alone, with or without goniosyncytialysis. Open angle glaucoma, on the other hand, depending on the severity, again, we will add procedures. Now, here in Canada, it's very common, in the US, it's very common for us to add a MIGS procedure, meaning a procedure that we use in the trabecular meshwork, like a stent or even a goniotomy. A 5-0 Prolene suture can be used to do a goniotomy, and this can reduce the pressure and medication count without creating a bleb. And this is helpful in mild to moderate cases that are not advancing. So I very commonly will combine phaco with a mixed procedure for mild to moderate and controlled glaucoma. If the patient is really uncontrolled, then I will consider doing a phaco trab. Although I like to do my trabeculectomy separate from phaco, I just find the success rate is higher. So there's no one procedure, actually. This is the real art of the procedure. But I will say the majority of combined procedures that I do are typically, in my practice, phaco MIGS. Phaco with admin-turner trabeculotomy, or phaco plus iStent, for example, are two things that we use commonly. And these are very safe, I believe, and can reduce the medications that have been shown over 5 years to have a benefit in reducing the need to go to more surgery.
Thank you. How about your opinion, Prof. Ahmed suggestion? Prof. Arsinov.
Are you asking me? Oh, sorry. I thought you were asking somebody else. Okay, well, I agree with what Ike said. It depends upon the patient. You have to look at each
Yes.
person, how bad their glaucoma is, what the cause is, angle closure. And in many cases, if I have a choice and the glaucoma is not bad, I would just do their cataract surgery first. And if the component is largely angle closure, they will just get better with the cataract surgery. Some of the ones that are severe, the most interesting types that I see that go from being not too bad to becoming terrible are pigmentary glaucomas. Pigment dispersion syndrome in some families goes along pretty well, and then suddenly they get their pressure goes to 50 or 60, and they turn in and they have changed from using 1 drop to now they need 4. And in them I'll do combined phaco trabs, and they do quite well. It depends upon the color of their iris as well. Those who have blue irises tend to do better with those procedures and don't need the mixed things as much. You have 2 extremes, but not many in the middle. And the other ones, I agree with what Ike said. They vary.
Thank you, Prof. One question more. This suaraku nggak masuk. Can you hear my voice, Dr. Ahmed and Prof. Arsinov? Okay.
Yes.
I repeat again the question. It's a question from Dr. Rauf and Dr. Prisma. In our country, if we didn't have regular, we only have regular proline 10O with curve needle, it is, can we perform your technique with our 10O proline? And in a polaris posterior polar or posterior capsule fibrosis in adult, it is better to perform posterior capsulotomy during the operation, or we must, or we can wait and perform JAG laser after the operation. Thank you. How about the result?
Yeah, I mean, I think I understand the challenge in access, and you know, if you have tenoproline suture and you want to suture a device or a lens to the sclera, it can be done. My recommendation is to be careful. The reason why tenoproline breaks are twofold. One, just from the chafing on the plastic of the lens and the suture itself can cause it to break, and second is UV degradation. The chafing is the bigger one though, so I recommend not just passing a loop of suture around an eyelet, but to actually make more of a cow hitch or tie a knot on the actual lens. This will reduce the chance that you have the rubbing of the suture along an edge or a sharp edge of an eyelet of a lens, for example, or a capsule retention segment. So that's one thing I will say. Others have also gone to using like 6-O-proline suture and using it actually instead, using a kind of a modified Yamani approach to fixate to the sclera. Sergio Canabrava from Brazil has presented some of these cases with, for example, some of our devices. So there are ways that you can get around it if you don't have Gore-Tex suture. As far as the posterior polar, yeah, I mean, do a YAG laser. I don't think it's a good idea to polish the posterior capsule if it's present in a posterior polar cataract. I would just do a YAG laser unless the patient is very young. If they're like, you know, less than 5 years age, I would do a posterior rexus and do a optic capture of the lens through the posterior capsule like I showed.
Thank you, Dr. Ahmed. For Prof. Arsinov, can you hear me?
Yes.
It is a question from Dr. Mahardika. How can we prevent vitreous aspiration during cataract surgery, and how we can handle it if we accidentally aspiration the vitreous? Thank you.
I'm not exactly sure what you're saying, what the question is. If you mean
the question is how we prevent vitreous aspiration during cataract surgery, and how if we how we handle it if we accidentally aspiration the.
So if you aspirate vitreous accidentally, you've either broken the capsule or you've broken the zonules. And so all I would do is I would release it, put in some triamcinolone, see where you have it, and go back with a retractor and remove it. You have no other choice. If you're referring to a high hyper, you have two choices. You can, well, a few choices. You can give, like Ike said, Diamox, and Dr. Hermon said also to give Diamox. You can aspirate the vitreous from the posterior segment before you start surgery, and you can use highly cohesive OVDs to push back the capsule so that your pressure in front of the eye is higher than the pressure in front of the capsule than behind it. My preference is to not aspirate vitreous if I have a choice. And if I have a shallow chamber, I'll just rather use a very viscous cohesive OVD and push back the capsule. And I really have had very few cases where that hasn't worked.
Thank you, Prof. Question for Dr. Diki. Pada yang tepi dari nukleus yang cenderung tajam, bagaimana kita memanage supaya kita bisa mencegah adanya PCR? For Dr. Diki, in hypermature cataract, sometimes we are facing the relative sharp edge of nucleus. How to manage this case to prevent the posterior capsular tear? Thank you.
We can do in the hypermature cataract. Tes. Halo, iya. Thank you, Dr. Indri. In hypermature cataract, we need to bring the lens fragment, the safe zone above the iris plane, and do not forget to protect corneal endothelium using dispersion. And don't forget to protect corneal endothelium using OVD. Thank you.
We have an interesting question too. Dr. Ike, what is the best pupil expansion device to choose? What we must choose in a small pupil and IVIS, intraoperative floppy iris syndrome?
Yeah, I mean, I think you probably get different opinions. I personally rarely use pupil expansion devices. I just find using the right viscoelastic combination and having your machine setting perfectly well with the fluidics are just perfect. No wound leakage. The chamber is stable. I have linear control of flow and vacuum. I can work under the iris for my rexus when I start off there. As long as I get a good rexus size, I'm comfortable without any kind of device. And I can get a good rexus under the iris, even if the iris pupil is small. And so that's my point. Now, I will say that if you have to use a device, I think a Malugin ring or some sort of pupil ring is fine. It can be very effective. However, in a shallow chamber or other issues like zonular problems, I think it might be more advantageous to use iris hooks because you can, maneuver them through, and have more flexibility in a shallow chamber. So that's my only comments for that. But it really doesn't matter what you're comfortable with and where you go.
Prof. Arsinov, how about our Phacoemulsification setting must be done in IVIS, intraoperative floppy iris syndrome?
Okay, in floppy iris syndrome, everyone has different ideas. Like Ike, I actually prefer not to use a ring for the pupil. Although I've used Malugin rings and I've used iris hooks, I find that you can actually stretch pupils with IVIS. They tell you not to, but if you put viscoat in the perimeter after you stretch the iris or as you're doing it, and then you put Helon 5 in the center, it doesn't move and stays dilated. And if you use low flow techniques like 15 cc's per minute, you can go and do your phaco and nothing moves. And you do it in the bag and everything is really quite simple to do. I actually find it preferable not to use Malugin rings in most cases because the more things I find I put in the eye, the less space I have to work in. And I like to just make it stable with the flow rate and the OVDs and do the cases like that. In terms of the phaco machine, the only thing that I'm going to change in more complicated cases is I will lower the flow rate to like 15 to 20, and I will then lower the bottle height in machines which set bottle heights to like 70 or so. If I use a Centurion, I'll lower the pressure. So the pressure in the eye is like 40 or 50 and not 70 when I'm doing those cases. And all you want to do is achieve stability. So the inflow is equal to the outflow and it's slow. So the turbulence isn't very much. And I use my machine on continuously variable pulse. So I don't burn anything because the pulses are spaced out. And you just take your time. It takes you maybe a minute longer and the cases go quite easily. I really don't think IFIS is that big a problem once you learn how to do them and you learn to use your OVDs and to dilate the iris. The one big mistake that I've seen is people say don't stretch the pupils. And I don't see any reason not to stretch the pupils. Because the thing is that if someone comes and has IFIS, why would we expect they only have IFIS? They can also have some fibrosis of their pupil. And it may not be only the IFIS, the paralysis of the muscle that causes the pupil to be small. So I see nothing wrong with stretching them. It doesn't flop when you have OVDs there. It only flops once you've taken the OVDs out. So if you do the case on low flow with the OVD stabilizing the iris, nothing moves. And when you stretch it big enough, it's easy to see what you're doing and it's very stable. And then when you finish the case and you take out the OVDs, then the irises flop like crazy, but then you're finished. So you just, take out the OVDs and go home. And it's quite easy. So the trick is to logically plan how you're going to do things in steps. I hope that's a good answer.
Thank you, Prof. Maybe the last question is for all of our speaker, Dr. Ahmed, Prof. Arsinov, and Dr. Diki Hermawan. In your experience, what is the very difficult case that you ever done? Thank you.
The most difficult case I've done? I would probably say, I had a case where early in my career where it was like, a 15 millimeter eye with a black cataract that was dislocated as well. And it was very difficult. I didn't want to do an extra cap or intercap, making a big incision. And then, having obviously a very small eye with potential risk for effusions and malignant glaucoma. So tried to phaco it. It was difficult phaco, eventually got the phaco done. But, all the turbulence and everything else, the patient developed choroidal effusions intraoperatively. And the capsular bag was intact. And I was just about to say, should I maybe stop now? But I didn't. And I continued going and I put the lens in, but the lens went through the bag because there's so much positive pressure. And then things continued to get worse and the patient developed a hemorrhage. And basically that was a very difficult case. And the patient didn't end up doing well. That's my worst case of my career, actually. But since that case, I've learned a lot and employed the techniques I talked about with the nanophthalmic eye. That's why nanophthalmic for me is very special because of that case, but also because of, the difficulties in those cases. So that would probably be my toughest one I can think of.
Okay. Well, let me mention my most difficult case that actually went well. I like to try to forget the most difficult ones that didn't go well. And I credit Ike for telling us about a problematic case, because I've had some tough nanophthalmos cases too. I had a guy maybe 15 years ago who was a cabinet maker, and I knew this guy because he'd come to me before for various things. And he was then about 75 years old and didn't want his cataracts fixed. And he was having his son working and taking over slowly his cabinet making business. And so he went in one day to help him and to tell him what to do. And he went and he smashed something and he got a huge piece of wood through his cornea into the anterior lens, ripping the capsule. And the piece of wood was probably 10 millimeters by 6 millimeters in the anterior chamber. And he had tears in his iris, and everything was not good. And it clearly was in his lens, and his lens was cataractus, and actually was a reasonably dense lens. He'd been stalling, trying to fix it. So I think, and also he ended up coming at night. And so I ended up doing him in the middle of the night with nurses that weren't accustomed to doing eye surgery. And I think I spent about 4 hours doing his cataract in the operating room. And I slowly put OVD in the already quite ample wound he had and tried to sort of stabilize the eye. I took out pieces of the wood slowly till I got all the pieces of wood out, and then tried to keep the eye stable. And I put a few sutures through the cornea to stabilize it, and gradually converted the tear he had in his capsule to a somewhat closely resembling a capsulorhexis, impaled the nucleus that was left on the phaco tip using very, very low pressure in the eye with a low bottle height of like 60 and very low flow, and very slowly took out the pieces to see if his posterior capsule was okay or not, or what I could see. and gradually put things together, managed to get the lens into the bag because the posterior capsule was okay, and managed to suture up his cornea because the incision was peripheral. And in the end, he could actually see quite well out of his eye. And I was quite happy. And he still comes as a patient. He's like 92 years old now, and he's still happy. So that was one of my things I looked at first and thought, oh my God, what am I dealing with? And in the end, it came out okay after 4 hours of sitting in the operating room.
That's usually cataract. I think the most difficult case is hard cataract because lens adjust directly to the capsular bag, and to deal with that usually I do capsular access, and then if possible I do iodization. But if not possible, I do sculpting of lens first in order to make space between capsule and lens. And then I will try to do dissection again. Also, I will increase US power, make a wide and deep groove. The main target is to divide the nucleus into two parts. In this situation, don't forget to use a visco, because as the saying goes, visco is cheaper than vitreous.
Thank you. I think it's very amazing session that we have. Almost of the question has been answered. Thank you for our three incredible speaker, Prof. Steve Arsinov, Dr. Aik Ahmed, Dr. Diki Hermawan, who have satisfied our curiosity about phacoemulsification and its technique. Tonight we are learn a lot from you, but unfortunately we have limited time, and it's the end of second session. Thank you to the participant for the very dynamic session. But before we finish the very nice meeting today, we would like to take a screenshot photo to all speakers today. It is okay? Please, to all speaker and panelists, would you mind to turn on the camera?
Sure, why not?
Okay. Take our picture. 3, 2, 1. Say cheese. Okay, once more. The committee say once more. Okay. 3, 2, 1. Look at the camera and say good night.
Good night.
Good night.
Here was Lauhi. I will hand it over back to Dr. Nurdin. Dr. Nurdin, please. Thank you.
Thank you, Dr. Indri. I had a terrific time on this web interaction and unfortunately not a lot of time. Before ending this webinar, I would like to extend my gratitude to the organizing committee for the hard work making this event possible. Thank you everyone for being part of this. Looking forward to the next amazing webinar with joint meeting Airlangga Global Ophthalmology. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam. Take care, everybody.
Thank you.
Thank you. Thank you very much.
Thank you, Prof. Arsinov.
Thank you, Prof.
Thank you.
Arsinov.
Been a great
We'll be
session.
send you the record of this meeting. Thank you.
Thank you.
Thank you. Dr. Aik have a lot of facts in here. You can read from the question and answer.
Well,
And
inshallah,
Prof.
we'll see you
Arsinov.
soon. And thank you,
See you
Steve,
soon.
for the invitation as well, Steve, to be with you.
Oh, thank you
Thank
very
you,
much.
Prof.
Ike.
Arsinov.
As
Thank
always.
you.
Thank you.
Thank you very much. I hope we can still contact in the future. Thank you so much.
I hope so.
Thank you, Steve.
It was a pleasure
Thank
coming
you,
to
Ag.
Indonesia. Yes, thank you.
If you want see our tracer, it's already. Tracernya di. Selamat ya, sukses. Terima kasih Dokter Yulia.
Firman nggak masuk ya? foto panitia dulu ya. Bisa foto panitia satu-satu. Ini yang pakai jaket. Halo, Junior.
Dok, lihat kamera, Dok.
Ayo. Dokter Susi bisa buka ini enggak? Foto enggak? Video.
Saya lagi pakai ini dok, pakai mukena dok.
Gak apa-apa. Ini Dokter Anta udah mencungel. Ayo kita foto ya.
Foto itu aja dok.
Ada dokter gede juga bisa di ini enggak? Di banyak full gitu ya?
Bisa pakai galeri. Wes. Makasih ya Anto ya.
Makasih dokter Gede Pardianto.
Makasih semuanya.
Sehat-sehat ya dok.
Sehat, sukses. Matur nuwun.
Udah di capture.
Terima kasih dok. Ya dok traveling ya.
Iya, kita terima kasih. Bisa di capture? Ayo, 1, 2. Siapa yang moto? Yang moto siapa dek?
Panitia dok yang udah capture.
Udah.
Dokter Evelyn udah mau dijemput Dokter Mahmud.
Kak, aku di rumah ini.
Oh lah.
Habis ujian terus. Sukses ya. Makasih AWCS. Hebat. Dokter Boy, makasih ya.
Sukses semua, Dokter Indri, Dokter Vicky, Dokter Nurdin, seluruh panitia. Hebat. You all rock.
Makasih ya, Tok.
Makasih ya, Dokter Anto.
Sami-sami.
Wes, boleh live ini?
Boleh tidur.
Tidur, ya. Matur nuwun, izin live.
Terima kasih banyak.
Tapi dok. Assalamualaikum.
Dokter Diki, Dokter Indri, terima kasih. Dokter Ruth, Dokter Kavin, Dokter Junior, dan semuanya ya. Faris, makasih ya.